What's going on, everybody? Thank you for listening and tuning in. We're back. It's Shane and myself, and we have a guest that I'm pretty stoked to talk with, and I think you guys are all going to get some pretty valuable information out of this conversation. I first met her out at the college, teaching at a regional training center up in the high desert at Victor Valley College, and she gave some awesome perspective on like the subconscious and depth psychology. So we've got Alex Jabr. She has a PhD in depth psychology, and she also is a licensed paramedic as well, and has a great wealth of knowledge that I think a lot of us can get some stuff out of. So welcome, Alex, and yeah, just kind of tell us a little bit about yourself and take it away. Yeah.
Thanks for having me, guys. Let's see. You covered most of it. I mean, I'm a PhD now, but I still maintain my license as a paramedic. I worked on an ambulance for about 15 years, and that was suddenly kind of ended with a medical injury. I had a 23 millimeter herniated disc, so I've got like nothing left between my L5 and S1 joints. So that kind of interrupts my plans, but I was able to pivot pretty well into education. I was already teaching at the college. I had been there for a few years. Really gave me a good place to land and kind of redirect my education personally from the emergency management path I was on to go into mental health and psychology. And so now I'm primarily an educator. I do independent education. I create continuing education courses on topics I find to be marginalized in the sense of, like, with death notifications, all the focus is on high performance CPR and RUSC and, CPC scores and survival. And I look at the stuff on the outside. I look at the stuff that gets kind of pushed aside because it's not as important. And I have a lot of fun with that, even with, death notification, CPR induced consciousness, the moral injury that comes from different types of situations. And I create CEs for first responders, and I teach all over the country and through my online platform.
Awesome. There is, so like, as far as the traveling and all over the country and the stuff you do, like, what's one of the main topics? I mean, that's kind of a stupid question. What's one of the main things that you're noticing that people are having an issue dealing with, first responders in particular?
I can tell you that I get requested for death notifications the most. But from my perspective, I think first responders are lacking adaptive coping mechanisms. Like, just my observation. So that's my bias. That's my anecdotal, like, just what I'm observing. It's not based on anything statistical. But if you're asking my personal experience, I think it comes back to coping mechanisms and the way that we're handling life.
Yeah, I think that hit the nail on the head. Exactly what it is. And I think with this podcast, that's one of the biggest, I think the main things that we deal with is the coping mechanism, and not just getting through life, but actually dealing with things as properly as you can with the tools that you have. And I think we're only able to do what we know, and without the right tools. And that's a big thing. You talk about that I heard, a few weeks ago is we only know what we know, right? To a lot of the degree that we live life, but there's a lot of things that we're just expected to just deal with, and we don't know how to communicate that or actually bring it up. And even the self-talk within our own heads of how to come to a conclusion of how to get over something. So as far as the coping mechanisms, can we dive a little bit deeper into that and get your idea of just some situations of coping mechanisms, like as far as death or the job or, just kind of daily life. Like you said, it's not just first responders, it's just us, just humans in general. I think we lack a lot of just coping with challenges in life.
Yeah. Well, I think the first thing to understand about coping mechanisms is that they are, by design, they're for survival. And we engage in them whether maladaptive or not. So maladaptive, the difference between an adaptive coping mechanism and a maladaptive coping mechanism is that a maladaptive coping mechanism over time creates more problems than it's solving. So an easy one is alcohol. why do we drink alcohol? To cope with the pain, to numb ourselves, to get a hit of dopamine, to kind of, relax, to fall asleep that night, to forget about the day. That over time now, it works. It's an effective coping mechanism, but it's maladaptive. So over time, it creates more problems. Your visceral fat goes up, your risk of coronary artery disease goes up, 10 types of diseases, type 2 diabetes. You have more risk for, behavior that you wouldn't normally engage in when you're sober, risk of your relationships kind of suffering. So the problems in the long run become greater. Whereas an adaptive coping mechanism might be that I'm going to go work with my therapist. I'm going to go for a run. I'm going to work out. I'm going to do things that are healthy, maybe meditation, that are going to create more solutions as I continue to engage in them. And I think that while alcohol and substances can be a really easy one to observe, I think the one that we overlook the most is the coping mechanism of staying busy. How many people do you know have multiple jobs? And to a degree, I think some of them, they have to because it's part of them providing, but there are people that will work above and beyond what's required to survive simply because it keeps them busy enough to not be alone with their own thoughts.
Yeah. Yeah, Shane, what do you think?
No, that's actually a really interesting take on that. Real quick, like go back for me. Where were you a medic at?
Southern California.
Is
I
that
was
where you
in
worked? Okay,
I was in I worked San Bernardino County mostly, but I've also worked LA County and Orange County.
gotcha. So after you finished up with that, that's what got you into pursuing your PhD and all this.
Yeah, it was kind of one of those pivots where I had to realize that if I wasn't going to be on an ambulance serving my community, maybe I could shift directions and serve the community I served with. So not necessarily working with the members of the public, but rather the people that served the public. And that's where I've managed to find a kind of a healthy balance, because it was pretty depressing to not all of a sudden not be a medic and not have an ability to do those things.
Yeah, I think that's a big part of it is like when you're part of this kind of tribe and then all of a sudden that's gone, you have this
Hmm.
gaping hole. You don't, you try to fill it. And it's, I think that ties right into what you're saying about that coping mechanism of just staying so busy that you don't have time to slow down and pay attention to what's going on or even sit in your feelings
Hmm.
and kind of evaluate everything. Um, Real quick for anybody that doesn't know what the death notifications are, what specifically are you actually covering with that?
So it's a curriculum I call death communication. So it kind of covers the psychosocial aspects of delivering a death notification. So whether it's an officer showing up in the middle of the night to tell a family member that somebody died, next of kin that somebody died in a car accident, most often it's usually in the context of you're working up cardiac arrest for 20, 30 minutes. You're supporting the family along the way. What are the things that you say to them while the arrest is going on, while you're working them up and resuscitating them? What do you say at the point that you determine that efforts are futile and you need to start to, prepare them for that, goodbye, and for you to stop, and really what goes on with their grieving process and what your role is in that, and what your role is not. So that's what that topic kind of uncovers.
Gotcha. Do you also go further if it's a line of duty death for first responders?
It's funny you bring that up, because that has been a topic that has been consistently brought up several times in the last couple of locations that I have taught at. And
Okay.
one of the things that I know this personally from one of my closest friends whose husband died in December, and he was an off duty. He was off duty, but it was active duty, death. And the stuff she had to deal with, it was such a mess when they notified her. It
Yeah.
was completely done poorly. And it was a department that should have a lot of experience doing this. Not to shit on them, but to a degree, if you're a bigger department and you've had deaths in the past, you would think that they have a system in place, and it did not appear evident that they did. And I think another thing that we were kind of talking about is, and this is something I learned. I was with the Cleveland Clinic a couple of weeks ago, and one of the sergeants from the local fire department or local police department was there, and she was teaching us that they actually have a file that they ask every new hire to fill out upon employment. And it's essentially a packet where they have to fill out information should something happen to them and they die, whether on duty or off. And it includes, who do you want notified? Who do you not want notified? Who do you want to be there? Different things that you wish the person was there to answer for you. And they don't have to do it. They can just put, a scratch through it, but they have to at least fill out the paperwork, even if it's to not engage in it. And a lot of people don't. They don't want to put the information in there. They don't want to, quote unquote, jinx it. But something that my friend and I were talking about, because the liaison that comes forward, who's supposed to take care of the family afterwards? And is there, an influence of someone? Like, could you think of one person you would not want showing up to your spouses, to support your spouses and being, that person? Put their name on it. Like, write down this firefighter so-and-so, stay away. This person and this person, priority. I want them to be with my family should something happen to me. Like, there's a lot of, it can be very empowering and also be very frightening to stop and think about those things. And I think that's why we avoid it and why it's not a common practice.
Yeah, I think that's great. I worked in Fresno, and there we actually had a line of duty death policy that we had that form, and we had to update it annually. So
Mm-hmm.
you could either elect no changes, or as your life evolves and things
Uh-huh.
change over time, you could go in and enter all the information exactly what you just said. And we had to use it, unfortunately, a few times. And yeah, it's tough opening those up and seeing, myself personally, I was listed as giving a eulogy for somebody, and I
Yeah.
wasn't expecting that. But me and him were rookies together, lived together for two
Oh,
years, and it was an off-duty accident similar to what you just described. And fortunately, we had that document to kind of guide
yeah.
us. But a lot of agencies don't have that. Where
Mm-mm.
I'm at currently, we're implementing something like that for these reasons,
Mm-hmm.
because when you find out too late. But I think in all this stuff in my mind dovetails together between, like, I really want to get into the grief with you, as well as like what you mentioned about the coping mechanisms, because I think that a lot of the people that we talk to are just, they don't know how to deal with all the stuff that's happened in their career, and a lot of it
Mm-hmm.
is gonna somehow connect to either somebody being tragically hurt, or worse, that they've worked alongside,
Yeah.
and just that nothing stays the same. I mean, you yourself, I'm sure you had partners for years, and then all of a sudden that stuff's gone, and you just look at, man, those were great times, but people kind of take it for granted when they're in it. And so just trying to make people more aware of it, I think, is a big part of all this. So,
Yeah. And
um,
I don't think it's weird to prepare for the worst. It's one of those things. Hope for the best, prepare for the worst. Of course, we all want to retire healthy, happy, and grow old with our spouses, but that's not always going to happen. I myself had to do so for my master's program. I got a master's in mental health. It's in grief and bereavement. That's where I wrote my death notification curriculum. And one of my capstones was to plan my own funeral. I
oh,
mean, from top to bottom, what I wanted to happen to my remains, who I wanted to do this, who I want, like everything. And after I submitted it, I actually printed it up and I put it in a folder for my sister. I didn't have a partner at the time that I needed to give it to, but I gave it to my older sister, and she had the direction, like, hey, if you outlive me, like, this is the letter that you'll open. And in fact, I even included, like, if there was something with I'm on life support, I was like, you get like 2 weeks and then cut it, and I even put the friends I wanted her to consult with, because I said, this person will be objective and not let her emotions get in the way with helping to like translate things for you, because she's not in the medical field. And in that moment, even if she was, don't treat people like they are, because in the moment that they're grieving, they are first that next of kin, they're first that sister, that spouse, that wife. They're not that nurse or paramedic. And so I updated it actually, and I was like, oh, I don't want this anymore. And I like tore it up and I updated it and I gave her a new folder. And I actually came across it a couple of days ago, and my fiance was like, what's that? And I was like, oh, this is what you'll look for if I die first. And so I just put it in the safe for him. He knows where it's at. So now he has a copy and she has a copy. And it also includes the passwords to my phone and computer, which can also be really detrimental. There's
yeah.
very little options for people to bypass passwords, especially on like Apple products. So those are little things you don't even think about, but you can prepare for.
Yeah, that's huge. I
Hmm.
hope you went big. You did a Hunter S. Thompson, right? You fired out of a cannon and everything. That's we. Uh, when we initially put that program in place in Fresno, a lot of the assholes I worked with, that was got the stuff that got written down was, you had to be wearing a clown costume to carry the casket. No chiefs are allowed at my funeral, that kind of
You
thing.
know what?
So, Yeah, no, but you got to take it serious, and that's great. And that I love that the passwords is huge.
Hmm.
Another thing I did with my mom, just for anybody that is dealing with family members, is getting a trust together. That
Oh,
trust bypasses
please.
so much stuff.
Yep.
It just cleans up the process afterwards, so you're not in all the red tape. You don't have to go through probate.
If
So
if the property, whether it's a dirt bike or a house, is in the deceased name, it is not, it goes to the state first. I've been through probate with my mother. It was an absolute, it's traumatizing, honestly, to have
yeah,
to go through that. And so that's actually something we're planning to do because we're getting married in March and his parents are the complete opposite of what mine were. And so they have all their stuff set up. They have a trust set up. They have their plots paid for. They're like, here's the paperwork. Everything's been paid for, just put us in the grave. And then, with us, we have to put a trust together. I have to, spell out what I want happening to my company when I die. So, that the education can still be available, but I can't be here to run it. So that's the kind of stuff that you really, it burdens the family member. It's a lot of burden for you, but it just gets transferred onto the family member and potentiated because it's coming onto them on top of the grief they're already experiencing. And a lot of times there's so much operational stuff that has to take place after a death that you almost have no time to process your grief. And so really this is a gift to them. And, I had a friend, one of our colleagues at the college had reached out to me. He goes, "Hey, would it be weird for me to write a letter to my family that they open if my, helicopter crashes?" And I'm like, "No, it wouldn't be weird. I think they would really like, I mean, you know your family better than anybody, but I think it's a very healthy concept to implement."
yeah. Um, do you get a lot of like when you're out there traveling around and working with first responders? Do you get a lot of engagement on this conversation, or do you feel like a lot of people don't like talking about it? Because I feel like
Mhm.
there's a mix of firefighters and cops that
Mhm.
don't want to talk about these types of things.
About their own death.
Yeah,
Yeah,
and
that,
just
like I
even like
said,
put that kind of
it's
stuff together.
and like I said, that this topic has come up consistently in the last few weeks, which is timely for supporting my one of my best friends who went through this in just December, just a few months ago. And so there's a thing kind of coming up with it. There's something collectively brewing. But what I will tell you is that when it comes to the death notifications and teaching that classes, it's about supporting the family member. It's about how to do this for the patient as an advocate of the patient for their family, but it really confronts the individual, the provider's own discomfort with death. So we don't talk about it directly, but it shows up in many ways, especially in the discussion of like, Eric, you saw my ethical dilemma that I present to the paramedic students, where I say there's been a single vehicle rollover traffic collision with one restrained minor patient that you have loaded up going to the ambulance, and you have one DOA that was ejected, and she looks at you and says, "Where's my husband?" And the answers are always consistent. It doesn't matter what part of the country I'm in and what group of providers I'm speaking to. Even the layperson. I've done this with a group of risk managers for one of our biggest railroad companies in the nation, and they say the same thing. "Well, they're taking care of him right now. We're focusing on you. You're our priority, and we'll find that out later." And it's just always about kicking the can down the road, and that tells me a lot about their own discomfort with their own mortality, whether they realize it or not.
Yeah, I actually that's funny you brought that up because as you guys were talking, that's the note I just put because I wanted to hit that point of when someone's getting notified, or how do you notify the truth versus, oh, someone passed or did they
Mhm.
die.
Mhm.
And I think with that coping mechanism, kind of going back to that what we were talking about earlier, we don't really know how to cope with the truth, right?
Mhm.
I feel like because that truth can lead down to how can I explain that better? The truth hurts. I should say that maybe that's a better
Yeah.
way to say it. And so to use the proper words, and you were talking about the DOA and how words can be so big with going along with the coping mechanism, because what we hear when we're going through grief like that, this is a point you hit hard with our subconscious. We may not hear because we don't know how or how to accept the words coming out of somebody's mouth if it's not direct,
Yeah. Yeah. You
right?
have to be very clear during that time because in a time where something stressful and chaotic is happening, their brains aren't working like ours. Like I could tell you my dad passed away in March, and you're gonna process that just fine with no problems. But if you are related to my dad and this is sudden and tragic news, it's gonna just misfire if I do anything but tell you he's dead. And there's a, a finesse and a process to building up to that. You want to tell the person you have bad news, you want to tell them who it's about, and then you want to briefly tell them what happened, and then ultimately the fourth step is to tell them that they're dead, but you have to use the words dead and died. And something I teach that a lot of people have resistance to because it's uncomfortable is that saying dead and died is the most compassionate, clearest way to deliver a notification.
Yeah, you brought this out as well because on your TikTok following, you brought up some examples when people went through that process of a call. And can you kind of go over that again, as far as people actually thanking the first responders of being truthful and honest, and to them,
Mhm.
it could have been a lie, like you were saying about how their subconscious is going to accept the information or not accept the information.
Mhm.
And you threw a TikTok thing out there,
Mhm.
and people really liked when the first responder said, "Yeah, your husband died or your wife died." Can you kind of expound on that a little bit?
Yeah. So what happens is, so I had talked about this topic on TikTok, and the video got in front of a large amount of the layperson, so people without medical backgrounds, and they just started sharing and sharing and sharing, and every single time they were sharing essentially their disdain and their experience where somebody wasn't clear with them. Somebody made them ask, somebody beat around the bush, somebody was lying to them, or they weren't clear with them, or they used a euphemism that really confused them. Like they showed up to a hospital and they say they're no longer with us, and they automatically, because they're also in a state of denial on top of the chaos that's going on in their brains, they go, well, where'd you take them? Hospitals are big places. They could be transferred. They could be in another floor. And so that was one of the things that kind of came up. And I showed you maybe, I think, 15 different types of comments that had occurred. But, the thing I've always said is I have about 400 questions that I saved them. I archived them all. I have about 400 comments that share similar testaments to that. And yet I don't have one where someone said they were mad that someone said that they were dead. Like, oh, they're just dead. Now, granted, there is a way to do it wrong too. That way I've done it wrong where I just blurted out that they were dead, and that wasn't appropriate either. But I have yet to hear somebody complain that someone was too clear with them and too direct. People want honesty, and it increases the trust that occurs between those two people when you're very clear with them and upfront.
Can you dive in? I don't know how deep of a topic this is, but can you explain a little bit why the subconscious reacts like that and why it can't differentiate when you're going through
So,
something?
so with us, so the process just really slows down. So when we say someone passed away, or they did not, let me see, where do I want to go with this? So when we say that they passed away, we can process that pretty easily. But at the point that we are under duress and we've got a flood of adrenaline and our fight or flight is going off, it's like taking a side street instead of the highway. So you get there, but it's like having to take the back way when the pass is shut down for, a fatality. That's the only way we can get up there. It's the fastest way to get up to the college for those of us that live down, in the valley. I bet you don't. You don't have to deal with that. I have been
Yeah.
stuck on that stupid pass many a times. So it's almost like having this slowing down a process. So it doesn't work as efficiently. So like I said, you still get there, but it takes longer to get there. And if you're confused and you're asking, and like then that person has to say, if the person you're trying to notify has to say, um, uh, are they dead? Then you're making them do the work for you. And then they usually tend to find a distrust with that as well.
I think what you just said right there, that's what I got from that portion of the class you were teaching at the college was now they're having to do your job for you versus
Exactly.
us doing the job for them because that is our duty, right?
Oh, yeah, yeah. Absolutely. That's exactly it.
Yeah. And I think when you said that, I'm like, that is so true. Now they're having to do the job for us, and they're having to think through something very difficult when they, at that moment, we should be helping and guiding them through that moment versus them trying to guide themselves when they're so lost.
Exactly.
And okay, yeah, sounds good. Um, and to go back on Alex's, Shane, I do have to actually drive on that pass. Up
Yeah,
that pass, I do get stuff from Temecula all the way up there. But yeah, so what do you think? I know we talk about the subconscious a lot, Shane, and that's something that we love. What do you what are your kind of key takeaways from that? What do you think about that as far as when someone's lost and actually us as professionals, or I think just us as humans, when a loved one is going through a difficult time like that, knowing how the subconscious works, and I think us as people being able to take that leadership role or take the reins at that moment and be a pillar for someone. What do you think?
I think it's something that I always tried to do on scene was try to be compassionate with people. I think I had a little bit more of a knack for it than some other people, but it's interesting to take it with the specific language of using the words dead or died. I'm trying to go back in my little Rolodex of all the times I've had to tell somebody on scene in as a captain or in any capacity. And there's not too many that I can think of where I'm like, man, I really did that bad, but I don't know if I've ever been that clear, been like, no, they're dead. Like not
Hmm.
obviously not delivering it without empathy, but to use that clear language. It makes sense to me, but I'm trying to think how many times if I said things like they didn't make it. Kind of like you're saying, taking that sort of easier route instead of just being direct and um yeah, it's interesting how just even the choice of the words matter so
Hmm.
much in
Oh,
that moment.
the words matter a lot, and it's not to any fault of your own. Honestly, I made all those same mistakes myself, and if I'm not really present and really thinking about my delivery and real conscious about what I'm about to say, I can mess it up very easily. And so it's more so to say and acknowledge that this is a failure of our system. This is not an individual problem. People were not taught how to do it, and we rely so heavily on not just experiential training, but really not good experiential training. Experiential in the sense that I learned how to avoid the family because that's what I watched growing up as an EMT. I watched my partners avoid the family, and I learned to do the same.
Yeah. So later that day, what we started doing is it's something we didn't do at the college until you kind of came out to this class, and it's something that we didn't think about because once again it's the system, it's what we're used to. Just, oh, in time, your experience, you'll learn how to communicate this better. But when do you start? Where do
Yeah.
you start? We
Yeah.
start in medic school, we start in EMT school, we start. And so that day I was talking to another one of the instructors, and I'm like, we every CPR they get ROSC.
Hmm.
They can't they does that happen? No. The
No.
majority of the time they're done, right? They're we don't get them back. If we get Ross, that's awesome. Like that's hey, we did our job, hooray, right? That's good stuff. And so in the scenarios in trauma or CPR or whatever, instead of somebody having ROSC, anyone that's listening, return of spontaneous circulation. So basically they came back to life. And so we started having them deliver the information of like, no, your kid died, or your wife died, or your father died, or your sister, or your grandma. And we started now putting that into our scenarios,
Hmm.
along with CPR, traumas, whatever the scenario is. And it caught a lot of them off guard initially. And it's very awkward for them. And you see
Hmm.
it to us that have been through it, that we've had to do those notifications, for years. It just comes in time. But I feel
Hmm.
like that's not right. There's a better path of success to be able to communicate those things, because now you're on duty, you're on your job, whether you're a doctor, you're a nurse, you're a fireman, you're an EMT, you're a medic. Those emotions are all the same. Life doesn't care about your rank of what position you have, because a death is a death. And when something now happens in a personal life, How are you going to deal with that? So now you got your job and now you got your personal life. And now when those two worlds collide, it can be a whirlwind of chaos and your body can just shut down if you're not taught, first of all, how to communicate with yourself, your self-dialogue, and then now communicate with the external world, if that makes any sense.
Yeah, it all bleeds over. Like the thing about first responders, they don't clock out.
Yeah.
They just don't. You know, even the ones that actually take their vacation and take time off, it's really, unless they are consciously decoupling and recognizing when to put the armor down. But you see it when, you know, they have to sit with their back to the wall, you know, at a restaurant. They have to look for the nearest exit if they're in a sketchy venue. You know, it's just it's one of those things they don't turn off, and to a degree those things are healthy to have. You want to have some self-awareness, but it's that, how do I put it? So I work with a lot of so ketamine therapy is my, you know, specialty, and it's what I studied in my PhD program. And you know, one of the things that I work with women, EMS providers, women in EMS, with a nonprofit called Wabi Sabi Circle that serves women in EMS, and we are about to start holding our we're about to start recruiting for our third retreat. And so the neat thing about, well, not the neat thing, but the thing that came forward on their own that I've observed, but it was really neat to watch them kind of reflect and determine this, is they were afraid to go back to, like, into their lives. They're like, we've done all this healing in this week-long retreat. How do I go back into the work that I was in, like, and armor up and put this defense up? And it's like, no, that's a good thing. Like the ability to compartmentalize and put this armor up that protects you while you're doing the craziest stuff that the average person can't even conceptualize and imagine. That's there for you so that you can continue doing it. But when you go home to your spouse and your kids, are you taking it off? That's the problem. The problem isn't being able to armor up. The problem is not being able to take it down and not having that connection, that emotional connection, that communication, and that vulnerability when you're home and off duty, and when your nervous system isn't threatened.
Yeah. The armor is always up.
Mm-hmm.
I would say 90, and I'm just throwing a statistic out there, probably not right, but over 90%, I would say the armor is always up.
Because
And
you don't even know it's on.
Exactly. Yep.
Why wouldn't it be always up? Like, you don't even know it's there.
Yeah, exactly. And I didn't. So when I got my medical retirement a couple years ago, that's when I started realizing my armor was up for close to 20 years. And people will tell you, you're not here, you're not present, you know, you're working so much, staying busy. We all do that, right? You're
Mm-hmm.
constantly busy, you're working the overtime, you're taking the classes, you're doing it because you are so afraid to actually slow down. I'm not saying staying busy is bad. That's not what I'm saying. I'm not saying don't be productive. That's complete opposite. Being busy is great, but it's, where's your nervous system at, and why are you staying busy? Are you staying busy because you're scared to be with your thoughts? I would say the majority, yes, and some are just busy because their personality. But to be able to differentiate the two is key.
Yeah.
I feel like, and for me, for a long time, I was just busy because I was afraid to be alone with my thoughts.
Yeah, it comes down to the intention behind it. What's your intent behind it? Is it because you're, you know, really cramming for this promotion and then afterwards you're going to slow it down? Is it just simply because you can't say no to any projects because the second you get 2 things off your plate, you acquire 5 more? I mean, really, only individuals can only answer that for themselves. But it's I would say it's the trickiest coping mechanism because it's the one we glorify. If someone binge drinks, somebody eventually, like on a regular basis, and causes harm, someone's going to eventually pull them aside and be like, hey, bud, like, we need to talk about this. But if someone's like working a bunch of overtime and they're always picking up your days, like, you know, you're always the one first coming in when someone has to go home sick, and you're also working at the college, and you also have this side gig, and you're also coaching Little League. Like, I mean, everyone's like, oh my God, you're so amazing. You do all these things. And you know, it could be a sign of a bigger problem, but you know, only that person can determine that.
Yeah, that hits deep because that's, once again, that's looking yourself in the mirror and really getting deep with yourself and saying, why am I doing what I'm doing? You know, what are your true intentions, right? And that's a scary place to get. And that's why I think a lot of people just stay busy. And like I said, it's not that it's bad. It's not trying to say anybody's doing anything wrong for their particular life. but I fell into all those as well. I'm just talking about myself,
Same.
talking about myself here. And it's one of those things that when that armor comes down and you look back, it's like a slow replay. And you're like, oh my gosh. And then you see it on other people. And then you just feel so bad. You're like, okay, it's okay to chill. It's okay. Just take a breath. And they can't. Like you can just see it on their face. You're like, okay,
Oh
okay,
yeah.
it's all good. I'm still here for you. Like whatever you need.
Now
I'm
I have, now that I can look back and go, I look back and I'm like, I have no idea how I survived. And it's like, no wonder, like, thank God I was in therapy because I was really doing a number on myself. And now the thing I have to work through is not getting activated by people who are really dysregulated and do that around me. And I'm just like I can't force anyone else to slow down, but it almost like, I wouldn't say it triggers me. That's not the right word, but it activates me and I get angry with them. And I'm like, would you just sit? And in reality, I can't do that for them. They don't see it. They don't even know that they're doing it. But I watch people abuse themselves over and over again and then blame it on somebody else when it's like, at the end of the day, we're all responsible for our own boundaries. There are some things out of our control, but when you sit down and inventory it, a lot of times, a lot of this stuff is within our control. We're just refusing to do the things that need to be done to reclaim it.
Yeah, I love it. What are your thoughts on this is, dovetailing into your coping mechanisms and having the right tools. What are your thoughts? I want to get into ketamine as well. I didn't know that was like your forte because I've never done it. Shane and I do deal with a couple, a few, but one in particular, Dr. Chris Rummick down here in the Orange County area. He does a ketamine, the SGB shot. I know I talked to you about that as well.
Yes,
You've
yeah.
heard about that. But I just lost my train of thought. But as far as the coping mechanisms,
How about have her cover, Alex? Tell us about like what you're teaching people for. You talked about maladaptive coping mechanisms. I'm sure you have some strategies that you're teaching on some of the good stuff because there has to be something good we can do.
there's probably a lot of
What
good.
what are- what are you teaching everybody to do?
Honestly, therapy. I think that's the big start. Like it's not the only thing to do, but I think that is where I am a huge advocate of get yourself a therapist before you need it. And here's the other thing too, is I'm not as a mental health advocate and person that educates in this area. I find it to be a big red flag when these concepts and these topics are delivered in this kind of fear-based, this is going to happen to everybody. Being a first responder is you're exciting yourself up to be exposed to a lot of trauma. That does not mean you're going to get PTSD. Everybody doesn't have PTSD. Not every, 10 people are going to show up to a really messed up call, and more than half of them are going to walk away and adapt just fine to it. But the way I see it is that everybody at some point or another is going to be affected, because what happens when it's your best friend at work? What happens when it's your captain, when it's your probie? Like, it's going to affect somebody you work with, or maybe even a family member, because we all know that this is a tight-knit community and a lot of times first responders run in families and generations. So it's not so much about worrying about, and I think we're so much more willing to help someone else than we are to help ourselves. And so when we keep in mind that this may not happen to me, but it may happen to somebody I care about, so I need to learn about it. And, that's where I come in. And the biggest thing that I advocate for is finding a therapist before you need it. Because quite honestly, if you're in this field, you could probably benefit from a therapist to help, prophylactically. And, God forbid anything happens to you. But I do think that there is a connection between physical injury and psychological injury. And so a lot of times we're having this trouble trying to get PTSD to be recognized as an injury, but I've seen physical injuries lead to PTSD because it was just, you know, lurking beneath the surface and manifested, during their time off when they weren't staying busy, they weren't with their crews, they were off duty, out on injury, taking narcotics, coping with booze and not speaking to anybody about it. And so I think our best defense is to work with a therapist to start.
So like you mentioned like a probie. How soon do you want somebody in the first responder world to start talking to therapists?
Yesterday.
Yeah.
Yeah, honestly,
Yeah.
because and here's my theory, and this is founded in some very loose, not we'll just say it's my opinion. So this is my disclaimer that this isn't coming from any major study. I have a theory that a majority of first responders actually had traumatic childhoods, and that if you did the adverse childhood experience survey, on which I've done with about, I think I had about 300 participants for it. But if you did like an actual rigorous study where you surveyed first responders from across the nation, you would find that a majority of them had a high amount of trauma in childhood. And while that puts us more at risk for things like depression, alcohol abuse, substance abuse, anxiety, PTSD, suicidal ideations, I think it ironically, childhood trauma actually makes first responders as good at their job as they are, because
I agree.
they were raised in chaos. This kind of stuff doesn't surprise them. They watch someone get abused or hurt that they couldn't help, and so they turn and become a cop or a firefighter so that they don't have to watch that someone else suffer. And while I think it becomes the thing that makes them so good at their job, it also primes that it's an injury that can be reinflicted very easily by these calls. And so that's just my perspective. I know there's a lot of holes you could punch in that, but
Well, I would say you're probably onto something with that. I've shared with Eric before on our podcast about when I went through my own stuff where I was like participating in the program at the Center of Excellence and the
Mhm.
stories I heard from the other guys. Now I'm in the other camp. My childhood was pretty basic. I don't really have any gnarly stuff from childhood. I was fortunate. So it never really crossed my radar. I mean, I knew that stuff's real, of course, but Eric and I have talked about that, like in the firehouse as a supervisor or leader or whatever. I would hold people accountable for a lot of stuff, but never even consider the why behind it and the
Mhm.
fact that you could trace stuff back to childhood. And so having that lens now has like changed my perspective drastically on how I handle a lot of stuff because I'm a lot more I mean, I haven't lowered my standards or the bar, but I'm also a little bit more empathetic about like, okay, well, how can I help guide this person to see something in a better way or do something in a better way? Because I
Yeah.
understand that they
Mhm.
have a different roadmap than I do.
Yeah, and trauma explains behavior, it doesn't excuse it. So you still have to hold that person accountable. And I see that happen a lot, is that,
Mhm.
somebody will tolerate poor behavior because of the person's history, and that doesn't do them any good. And so trauma explains it, which will help you in your lens in being more compassionate, more empathetic, and allowing space for maybe some healing and reform to happen. It's not going to happen on its own though. They have to work with a professional. They have to work with themselves. They have to be willing to do the work themselves. And it helps to do it with a professional clinician to help guide that, and the right clinician, right? But it still needs to be held accountable too. So that's good that you have that practice.
Yeah, that I don't go down a rabbit hole, but that's been pissing me off lately with a lot of these people that are abusing the fact that mental health is being embraced, I think, in our world. You hear these things sometimes about like, oh, there's nothing there for us. And it's like, dude, that's all anyone's talking about right now. Everybody in the fire service and
Yeah.
first responder world is talking about mental health and having access. Now, is it all good? No, I mean, it's a growing kind of process that's being built up, but um regardless, I just had this conversation the other day, and it's one of those that like uh, I think that's one of the bummers is that you get the people who kind of hijack it for their own personal benefit or gain. They like to lean into how they're a first responder that's fighting PTSD and mental health, and it's like, well, you also signed up to do this job, so if you're not built to do this, and you're not, just like maybe pack it up and do something else. So. Sorry.
No,
I swear to God,
I
this is
love it,
timely
dude.
because it just happened last few weeks. You have no idea. So it's one of those, but so I love what you said, right? Like it doesn't excuse it.
Mm-mm.
It does not excuse you being a dick. Like you need to do
It
your
really
job. You
doesn't.
need to do it. So let me ask you this, and let me play devil's advocate. Like, talk therapy wasn't something that really did much for me. Not to say I had a couple of different clinicians I've interacted with who are phenomenal. I mean, they're excellent people. I've
Hmm.
really enjoyed my conversations with them, but I don't go. I don't think about that. My personal coping mechanisms have shifted from things like binge drinking to I use my sauna. I use a cold plunge. I mean, this podcast, like a lot of conversations, which arguably I suppose is therapy in and of itself. So.
Therapeutic.
Would that yeah, would that be another, are you pretty solid on advocating that somebody needs to be talking to a professional at all times?
Yes, and okay, so I will say this because I keep my mouth shut when I hear it, but when people say like working out's my therapy, like knock yourself out, it is an adaptive coping mechanism. Good job, but it is not going to touch your psyche. It'll help your nervous system and it will help, build your health. And I'm not saying it's a bad thing, but it's not enough. And you know what? I will honestly say that talk therapy doesn't work a lot of the times. I enjoy my talk therapy, but talk therapy does not tap into the subconscious. You need to do stuff like EMDR. You have to do stuff like ketamine therapy. Even clinical hypnotherapy will tap into the subconscious, but we're never going to undo that programming that's embedded deeply behind this wall that we can't penetrate in our conscious state without the assistance of those tools. And talk therapy will only get you so far. You think about, you've heard the saying that like 99% of our actions and behaviors and thoughts and feelings are unconscious programming. Right now we're using 1% of our mind, 1% of that, of our brains. How do we get to that other 99%? And it's through those mechanisms. And then the talk therapy complements it. The talk therapy uses these things to help. And then there's different forms of talk therapy. Don't get me into that. That can get really confusing. But I think it comes
Mhm.
down to working with a clinician that you're comfortable opening up with and being your true self, and a clinician that will actually hold your feet to the fire as well when you need to hear it, and building that trust and that rapport. But it's more so like, yeah, if things are unremarkable and things are really stable and you're not digging into like some deeper stuff, it could feel like, oh, this maybe help, maybe not. But then, for me, I will say that I was going to therapy because I was advocating for therapy to other people. And I was like, well, let me put my money where my mouth is and actually start seeing a therapist. And so I did. And the first year was like just routine. My insurance covered it. So I went and saw her every Tuesday at 5 p.m. And then I had my back injury. And then all the trauma I dealt with under the age of 5 was like front and center. And I was coping heavily with alcohol. And I was isolated. I felt like nobody could actually see my injury. It was really challenging. I wasn't working as a medic. I had no idea what my future held. There was an identity crisis happening because my identity was very much wrapped up in being a medic. And I loved being a medic. I was one of the few people at AMR that actually liked my job, so.
What?
So right, how unfair is that? It got taken away from me, and I was like, I was happy here. I wasn't going to leave. And maybe that's what
You-
had to happen because now I'm doing things that I probably wouldn't have done had I stayed there. And so I'm grateful. But the bigger thing was I'm so glad I had that trusted, established rapport with someone that helped me navigate that really dark period of my life. To try and find her while I was wounded would have never happened.
Yeah, I want to hit that point because the system again. Shane and I talk about the system failing us, and there's anyone listening, man, rewind that part, what you just said, take notes. There's a lot of nuggets that you just said in there. Um, but finding the right person that you're comfortable with, right? Because I think there's a lot of people that have gone to therapy or tried to talk to somebody, whatever it might be. Oh, I just didn't get along with them, or they made it worse. I didn't vibe with them, and they just give it a couple times and they're done. It's like, well, you don't just stop,
It's like
right? There's a
dating.
lot of what's that?
It's
Yeah,
like dating. Did you just
exactly.
stop at your first like bad date?
No, that's a good perspective, right? And it's like you got to keep rolling with it because the energy and the vibe is real.
Mm-hmm.
What you're saying, and you have to find someone you can connect with. But there's a big thing you said. It's like to be your true self. And I think in a world where everybody's trying to be somebody else, they aren't
Mm-hmm.
their true self. Now they uh, go to therapy or something hits them in life and they're still having that armor up. Because when you let that armor down and someone is actually like, hey, just you can be butt ass naked right now and I'm still going to be here to help you out, right?
Mm-hmm.
And I can say something. That's what Shane's done for me, right? He's accepted me as a true friend and let me just be my true self. He's like, I ain't gonna judge you. You just be yourself, bro. I don't give a crap who you are. Like, I'll love you for whatever. But I did have that when I went to my program in San Diego. That's what my doctor did with me.
Yeah.
And up until 35 years old, I was never I don't want to say never, but it was very hard for me to be my true self with anybody. There was
Mm-hmm.
always a wall up from childhood trauma, religion, the job,
Mm-hmm.
whatever, whatever the thing was.
It's conditioning.
And yeah, and so when someone is like that and they look at you in the eyes, your therapist, I'm saying, when you find that person, it really is a big shift in life of where you're able to find, they will bring out things because they studied the brain, they studied the subconscious, they studied all these things. That's their master, that's their craft. And they will ask specific questions and you're
Mm-hmm.
like, oh my gosh, I never thought about that. And when you can connect with someone on that level, it humbled me so much. And I think if anyone can find that, it really is a big shift in your mindset,
Mm-hmm.
in moving the needle forward, whatever that is for you, the
Yeah.
job, marriage, personal life, whatever it might be, because the majority of the time it is our perspective and we're not just seeing it correctly, especially if our armor's up. We're definitely not seeing it even near how we should be seeing it.
Yeah, they can act as a mirror. And so really to come back to what you said, Shane, I do agree that talk therapy alone is typically not enough. It's not. And so find yourself a therapist that is certified in other things. And I use EMDR as my most common recommendation. I'm a big fan of ketamine therapy, but there's a lot of barriers and access to care and also access to high quality care with ketamine therapy. But EMDR is more mainstream. It's been, there's a lot of trauma informed therapists that are using it, particularly with first responders. And I just think it's a fantastic option for people. I mean, then there's also, my therapist the other day told me to draw. She was like, I want you to do an art therapy project. And I was like, all right. I hadn't done art therapy in years. I used to work with a music and art therapist as well. So that's another form of therapy that kind of digs into the subconscious. My therapist was like, all right, I want you to draw yourself picking an apple from a tree. I was like, okay. I did it like 5 minutes before therapy. I had like 2 weeks to do it. Did it 5 minutes before therapy and she annihilated me. I was like, how did we get here? I'm sobbing. We're talking, we're connecting dots, this whole thing. And I was like, I thought this was going to be fun. It is not fun. But they have the way of like pointing out, like, oh, did you notice you drew this way? Did you notice this is where your feet are turned? Did you notice that you drew it so it was hard to like, and then she, she's like, look at this hole right here in the tree. She was like, that's a wound. And I said, no, that's the squirrel's home. And she's like, nope, that's a wound about the age of 5 years old. And I was like, shit. And so we unpacked that together. But they use these mediums to help because the subconscious comes through in art as well. A lot of things that we draw is actually our subconscious speaking. Another way that you access your subconscious, if you can remember your dreams, dream analysis, dream tending can also be a way to speak to it. And the subconscious says some wonky stuff, let me tell you. So but yeah, as a baseline, it's just good to have somebody in your corner that has your back and that's going to feed you a different perspective from the experience of someone that's worked with people like you over and over and over again. So they have they have their own Rolodex to work with.
Yeah, that's the hardest part. I think that pool's really shallow. So that's what we're finding is like where I'm at right now out on the coast. It's in our op area, trying to connect people with the correct therapist is very difficult. I mean, that,
Mm-hmm.
like I said, the pools are very shallow, and um, as well as like the barriers to treatment, as you mentioned. I'd like to get
Mm-hmm.
into the ketamine here in a second, but just, like even just the funding mechanisms on how much it costs for a person to go and how often are you going to go? I mean, if it's an
Yeah.
initial couple times a week, you need to go participating in an EMDR, whether it be CPT, CBD, any of that, or CBT,
Mm-hmm.
any of that stuff. Basically it costs money, and that's usually a big barrier for people. And so I know for sure I've seen that and had many discussions with people about those things. But yeah,
With
if
or
you go ahead.
I was going to say with organizations, it always makes me laugh when they say it costs too much money because I ask them how much does it cost to have somebody out on injury for
Yeah.
PTSD.
Yeah.
That'll rack up into the millions with just a
Oh yeah.
handful of people over a couple of years. And then we're talking recruitment, retention, um, you know, people burning up all their overtime or all their sick time, and then you've got people covering for them. I mean, the cost to do nothing and to offer nothing far exceeds the cost to implement these programs. But from what I understand, it comes at a different banks, like different kind of budgets. And
Yep.
so they go, well, that's not our problem here. And they'd rather be reactive. We're so much more reactive than we are proactive when it comes to mental health and wellness for first responders.
Yeah, I mean, it gets dicey from a labor management perspective, because when you start getting involved in a work comp and things like that on whether or not, how are we going to cover a person? Like, it seems so simple to just put the person off work. And as a BC, I mean, I don't want somebody at the station that can't function and needs help. We want to get them that help. But then
Yeah.
there are administrative, you know, red tape, which sucks. And it's not like I'm a fan of it, but you don't have a magic wand to just say, oh, nope, this is how it is. Now we advocate and do what we can, but it ends up and um it's what you just said. It's being reactive. It's unfortunately like it wasn't planned ahead. Like the whole example of your LODD packet being like pre-packaged up. We should have the same thing. This is part of what our whole podcast mentality is about, is in the fire service, the RIC team, the
Hmm.
rapid intervention crew. It's the
Hmm.
same thing we're talking about with the mental health, is have people around you that have that mentality where they're watching your back and they see you're starting to get yourself a little bit too far, and they can reach in and grab you before you go beyond the point of no return. um but it's a pre-planning thing, it's a mindset, it's all those things together. And
It's being
so
that person too. You being that person for other people first will attract other people who will be that person for you.
yeah, totally agree.
Mhm.
What um so tell us about the ketamine. So how did you get into that? Because so I've done 3 sessions myself,
Okay.
a little bit. Our big thing has been the SGB, the stellate ganglion block shot. That's where we Eric and I have built partnerships that we've probably sent at least 150 people at this point through a process, starting with the SGB, just based on
Yeah.
what we were educated by. We work with a Harvard trained psychologist frequently.
Hmm.
Doc Romig, that he mentioned earlier, has been our primary that takes care of our people. Um, and myself, that was my biggest benefit, was the SGB. And then I went to Chicago to the headquarters of a company we were working with, and I watched a couple go through what they call the SOFT protocol, which is Special Operator Forces. But this guy was a retired Air Force Special Forces guy who's now a fireman in Massachusetts, and his wife had been a secondary trauma for 25 plus years with him. She'd gone through it all, and he was
Hmm.
in a bad way. And him and I met via text message through a friend.
Hmm.
I just stayed up with them. We met up in Chicago. It was a really cool experience for me to watch him and his wife go through the whole week. And basically, they started on a Monday with ketamine, Tuesday ketamine, Wednesday ketamine. Thursday was the SGB shot on the right side. Friday was the left side with one more round of ketamine. But
Hmm.
each session was guided by this Harvard trained psychologist. Like after the
Excellent.
session, yeah, they got to go in and they did it individually and they did it as a couple. So there was like,
Wow.
I don't remember, there was like 1 or 2 days where they were like in the same room together. I think there were 1 or 2 days they had them separate, and then like it was a cool experience to watch personally.
Yeah.
But I have very
Yeah.
minimal like personal experience. Like I said, I did it the 3 times, but
What route
anyway,
did you
so
do?
infusion.
You did do an infusion. Okay.
Yeah, I did an IV infusion. I didn't have a guided one. I did
Hmm.
it up in the area I was working in the Central Valley in Fresno.
Hmm.
I talked to Doc Romig, who's our primary guy that we use. I would have preferred to do it with him, but it just wasn't lining up at that moment. To be honest, I was trying to use my flex spending money before the end
Yeah.
of the year, and I
Fair.
talked to Eric about it. I said, hey, I feel like I was like, I'd read all this stuff, I'd seen all this stuff about,
Yeah.
ketamine kind of helps you kind of find your way in those little things, you get that voice in your head talking to you that you can't really put your finger on it, kind of thing. So I was like, I'll give it a try. So I went in with very clear intentions. I was very much like, okay, this is what I want to try to get out of it. I know they recommend the 6 sessions. I ended up doing Monday, Wednesday, Friday, but I think it was more like where I went. Very clean, very good, solid people, but just it
Yeah.
was very much like, okay, you're done, see you later. And
Yeah.
then I didn't set that part up well, so I just said, you know what, I'm gonna wait. If I do this in the future, I'm gonna set it up where I have a couple weeks with Chris, do this
Yep.
right. But anyway, so what? Um, I don't know how much you know about the SGB, but what Eric and I have recommended to a lot of people is like starting with the SGB, and then if that's not enough, then they go and can start doing that ketamine stuff. Sometimes they do it
So
in conjunction.
help me understand this because I've heard I'm aware of what the Stella block is, and it makes sense, the mechanism, right? It makes sense that it creates a block so that, your nervous system has basically you could probably explain this better than I can, to be honest with you. But one thing I'm curious about is it blocks an impulse, but why is the impulse still coming up?
I don't. So the way I understand it is like Doc Shauna Springers, who we use quite frequently for a lot of kind of our consultations. She's done some therapy for random people in our circles, and she's an expert in this field, as is
Mm-hmm.
Bromate. Essentially, they call it the surgery before you do the rehab. So
Mm-hmm.
picture that you've torn your ACL.
Mm-hmm.
I tore my ACL at a structure fire back in 2019. I went to the
Oh,
workers' comp doc. You know how shitty they are.
yeah, they were
They
fun.
Of course, what they tell me is probably like they told you with your back, go
Walk
get
it
some
off.
physical therapy, you'll be okay, right? Like,
Yeah.
and it was the same. Go to physical therapy. I'm like, I've been an athlete my whole life. I know something's wrong. I'm not here because I need you to tell me to elevate my knee and put ice on it. Like, I can figure that part out. Something popped. I need some kind of medical intervention. Like, I can't fix my ligaments, that's
Yeah.
unfortunately. So I need surgery. Of course, the doc says, no, you're fine. Go to physical therapy. Now, had I gone to physical therapy, it's not that that was a bad thing. I could have got some benefit to the muscles around, right? I was strengthened up things around it, but at the end of the day, the ACL is still torn.
Correct. Yeah.
Now, maybe not in 6 days or 6 months or 6 years, but at some point I'm going to step wrong. My knee's going to hyperextend. I'm going to tear everything else in my knee. Now I potentially need a knee replacement. I need multiple ligament repair. This catastrophic blowout now could have been prevented if I would have started with this. What I really needed was the surgery. I need the ligament repaired. Does that make sense? And so
Yeah.
then
Yeah.
following that, now I need to go to physical therapy because now I just like they put a cadaver ligament in my knee. Now I need to go and I need to do the box squats and stretch and go for my PT a couple times a week until I get my legs strong again. So the way Doc has explained it to us and what we kind of push forward to everybody's like it's like your ACL's torn. It's an injury. It's not PTSD. It's the PTSI. Get a SPECT brain scan. Your ganglia is on fire. All the stuff's going crazy. Like you said, you're always a first responder. You can't shut it off.
Mm-hmm.
So if that's the proof, you're looking at a SPECT scan that shows unequivocally that
Oh,
your brain
okay.
is all lit up. Okay, you have an injury. So it's not about. I mean, yeah, it could be childhood related. Could be what you've seen on the job. Could be as simple as a single call just triggered you to where you're stuck in the
Mm-hmm.
fight or flight. So the way I picture it in my dumb brain is that people that get that SGB shot, it's like rebooting your iPhone. When your phone freezes up and has a problem, and you do the hard reboot or your computer or whatever, and then it fires back up and magically works great again.
Mm-hmm.
That's what these SGB seems to do. It's like a biological reset. So it's a
Got it.
biological intervention. It doesn't change who you are. Me and Eric tell people all the time, if you're a dick before the shot, you're going to be a dick after the shot. That doesn't change. If you're just one of those people that is super negative and the whole world's against you and you're a conspiracy theorist, you're still going to be a kook when this thing's over with. But if we look at your biometrics, we would bet that we can see there's some change. So the
Okay.
stuff that convinced me to even pursue it was watching people's vital signs change. So people whose heart rate was consistently 100 beats a minute at rest,
Uh,
within a day, their heart rate is back in that 60 to 80 where it should
oh,
be.
shoot.
Okay.
Mine's pretty high.
The IBS, well, and that's something that, like, when you look at the biometrics, like the whoop
Oops.
strap I'm wearing, yeah,
Yeah.
it's my wife was that way, Alex. Her resting heart rate at all times 100 beats a minute,
It
um,
freaks my fiance out. Like he's actually worried about my heart. And I'm like, it's always
as
been
it
this
should.
high. And I'm
Yeah,
like,
I'm telling you
uh-oh.
right now, go get an SGV shot because that's where
Okay.
I mean, honestly, my wife, if for no other reason than that, she didn't necessarily like have like tremendous relief and results from the SGB, but her heart rate dropped into the 60s and 70s where it belongs. So I showed her mathematically across 30 years how I'm like, you're talking about incredible amount of beats
Mm-hmm.
that your pump doesn't have to do now as you sit at rest, because of it relieved that anxiety of that system in overdrive constantly. And that's one of several vital sign markers we saw. Eric and I talked to guys with IBS, really bad irritable bowel syndrome, that had been to every kind of doctor, colonoscopy, could never get relief, got the shot, and it resolved that stuff.
Wow.
And that, a lot of
Okay.
that has that vagal response, the whole scare the shit out of you. It's like it's literally like a fear-based sympathetic response, is to have that problem in the bowels. And
Yeah.
then I've seen blood pressures, I've seen sleep. I mean, my own sleep. I can show
Headaches.
you. Yeah, I mean, all kinds of other types of getting off pills. Some people that were like hooked on things like certain types of SSRIs.
Mm-hmm.
A guy I knew was in Xanax withdrawal, got it. He hasn't touched anything since.
Well,
A lot of people like myself, like I don't even want to drink. I used to party and have fun, like all first responders,
yeah.
and I don't even have a desire to drink. I mean, I go to
Yeah.
bars with friends, and it doesn't bother me at all. So there's all these little things like that, but it's the surgery that I see, and then because I know people who have done the ketamine or have done other stuff too. Another thing I want to talk about at some point is the ibogaine. See what you know about
Mm,
that, because that's starting to pick up some steam. Um, but the more that I've seen, the more I'm a believer that the first step in the process is the SGB. Get that ACL repaired, and
I could
then
see that.
I could see where the ketamine is like
Yeah.
the rehab. Now you're going in and you're really like, but it's a prime. Doc Springer. I'll say this and I'll let you kind of tell us what you think. But she says it's like the primer on the hardwood floor that you're going to put a stain on.
Mm-hmm.
So if you put the stain down on it when it's dry, like it'll take, but when you go and you wipe it up, it's not the same. Whereas if you just get the wood wet and it opens up the pores of the wood and you lay the stain down, like man, it just
Yeah.
takes so much better. So she calls it like a primer. So
Yeah.
then the advocate is to then do the work, right? Like do your
Uh,
talk therapy consistently with your mindfulness, your sauna, your ice baths, your
yeah.
your meditation, your journaling, your prayers, whatever your jam is.
Yeah.
Um, and it also clears out the clutter. I mean, so many people report they're like, dude, I'm calm. My mind's not going a million miles an hour. And that stuff comes back over time if you allow it to. I mean, something that you
Sure.
mentioned is I'm super busy, but I'm always trying to pay attention to it and be like, okay, I'm getting out over my skis. I need to like throttle back, spend some time at home, sleep in. It's okay. I don't need to
Yeah.
throw my whole day up with all this stuff. Like it's okay to just chill out. So um, that's been the kind of the best sort of like path that we've been able
Mm-hmm.
to help people find.
Yeah.
But the ketamine, like I said, I have minimal. So what's your experience with all that, and what do you think?
So, and I will say that I started paying a little bit more attention to the Stella block when I heard it was being coupled with therapy or with ketamine therapy, because then I thought, oh, that's probably a really good synergistic, thing. Because they work on different mechanisms. I can already tell just based on what little I know. And so where I got interested in ketamine therapy was that this was back in 2018. I started my PhD program, and day one, you start contemplating what you're going to write for your dissertation, which dissertation is a 2-year, couple hundred-page paper that you have to write in order to graduate. And so a majority of people who start their PhD programs don't finish because of the dissertation. So I was contemplating this very early. And it took a couple of years for me to figure out what I was going to study, but I knew day one that I wasn't interested in studying the problem. We knew and I knew I wanted to study something for first responders, but I wasn't interested in looking at more suicide rates and more depression, more PTSD. I didn't want to learn more about that. We've got it covered. I think we know there's a problem, right? And so I thought I want to study a solution. And I didn't know what that solution was going to be. And over time, this like very blurry image that I had in my mind's eye got very clear, and it became ketamine therapy. And I realized that this was right up my alley because it's a weird thing. It's not very mainstream. I really had to lean into and figure out and dissect, okay, why is there a stigma around this? And how ironic that a treatment modality would have and carry a similar stigma as the disease itself, as the, disorder, without order itself. And so that's really where it started. And I will say ketamine therapy has been around. They started studying it in the early 2000s. late 90s, early 2000s. And I would say somewhere around 2014, 15, it started picking up as far as popping up as ketamine clinics. So you have a lot of drip clinics out there that will just, hey, have a nice trip. We'll monitor your vitals from somewhere else. We'll see you when you get back from space. Don't operate machinery or buy a house. And, sayonara. As they literally tell you, they were like, don't make any big decisions. And they tell you to go on. And then there's other ones that, optimally they have a guide in there with you. They talk about your intention going in. They set the setting, the intention. They maybe guide you during it. And then afterwards you have integration. And it's important, I would say, when looking for a ketamine therapist, or a practice, I should say, is find out, do they have clinicians that they partner with, or is there a clinician within the practice that you can do your integration with? Because that's really where it's at. Is I don't really want to talk during my ketamine therapy, but the stuff that comes up that I want to process with somebody and then have them help me figure out where it fits into my life and where these reflections and these themes and these emotions that come up, there were one of the most challenging ketamine therapy session I had. I healed my relationship with my mother, who's been dead over 20 years. That's the best way to describe it. It's like this, it is mystical, and there's a lot of, science-based, I remember the first time when I graduated with my PhD, I got invited to speak to a group of physicians about it. And they're like, can you not say mystical? Okay. You can't help what it is. It truly is that. You have this dissolving of timelines, and you have access to these wounds that have calcified and hardened in your subconscious, and you can go back and tend to them the way they should have been tended to in the first place. And that's the big thing. You have this ability to go back. It's like, let's say you have a broken bone. I've seen it. I had a patient like this one time where we were there for something completely different, and she had an extra elbow. And I said, what happened there? And she was like, oh, I broke it when I was little. It was never set right. It's like going in, breaking the bone, gently, but breaking the bone nonetheless so it can be reset properly. It gives you, it primes your mind and your brain to do that. And it's even more effective if you work with a clinician that can help you process that information and do something with it. So I always tell people it's about protecting your investment, not just your financial investment, but your time investment that goes into it. And all the research that's out there doesn't integrate therapy. All the research that we've seen that shows that ketamine works, it's just with the medicine alone. But it works longer and your effects last longer if you are continuing to keep those changes at the forefront, because you're working on them. You're consciously, actively working on keeping those things up. And the other thing I always tell people too is that the window of therapy is about, like, the treatment itself is only about an hour. You're sober about an hour after that, just depending on the route. So this is based off of intravenous. But your therapeutic window is up to 3 days. You have a good 2 to 3 days where you have the ability to impress upon your psyche. And so, someone asked me not too long ago, oh, can I still smoke? It's like, are you trying to quit? Well, yeah, then no. You don't want to reinforce a bad habit. If you're trying to quit, why would you let yourself chain smoke when you have that kind of impression? You have that ability to impress on your psyche. At least consider smoking less and be aware that you're reinforcing a habit you're trying to break at a time where you're going to reinforce it stronger. So in that time period, abstaining from alcohol if you're trying to, break a bad relationship with that, choosing healthier foods if you have, a tendency to cope with food. Stay away from family members that you argue about politics with, because that's not going to do you any good. Be mindful about the stuff that you're ingesting, not just as food and drink, but also as media, music, social media, TV shows. You don't need to watch some war movie where someone's getting their brains blown out, like as you just got done with this therapeutic experience. You really want to foster and nurture what you're trying to reinforce more of. And so that's really where I find the magic of ketamine, is that even though you're going in for a 1 hour session, you're getting a good 72 hours out of it, which is why the talk therapy comes in the day after, ideally.
Is it your recommendation to do the 6 or so sessions in about a 2 week period? Is that what you're finding, or like for somebody that's just going to start?
Yes and no. Okay, so
Okay.
the 6 sessions in 2 weeks was an arbitrary protocol that was developed in the early 2000s by Yale. It was the first clinical trial that was run, and that's just the number they chose.
Mhm.
I'm not here to say it shouldn't be done that way. I'm not here to say it shouldn't. I think that, and this is a conversation I've had with a couple of practitioners where they said, no, it has to be 6. And I said, well, what's worse, 3 or 0? They can't answer me. Now, what I will say in support of the 6 is that each ketamine therapy session potentiates the last one. And the benefit of doing it in a 2-week period is you have a little bit more control over your schedule. And so like somebody might not be able to take off 3 days every month, or maybe they can afford to, trade a couple of weeks worth of shifts and make sure that they have those 2 weeks off, because you could go back to work the next day. It's out of your system. You're sober within an hour afterwards, but why would you want to, is what I ask. Give yourself a break from work to concentrate that time.
Yeah. Good luck with the first responder. That's me and Eric deal with this all the time. When we send people to Irvine to get their shots, and
Mm-hmm.
guys that we know drive from all over California, usually after, as we've laid it all out, hey dude, go down there, get a hotel, chill out,
Mm-hmm.
go that morning, get it, relax, go back, sleep, go to look at the beach.
Nope.
You'll be ready for a steak dinner that night. Normally what these idiots do is bomb down there the morning of it, through the traffic of LA,
Which is
go in. They're usually,
horrific.
yeah, they're 20, 30 minutes late, so they're already stressed out. They go in, they get the shot, and then, within 30 to 45 minutes or an hour later, they're in the car again. Most recently, a friend of mine who was with his 81-year-old mother because she wanted to see the process. She
Cool.
was driving him through LA, which he
Oh God.
spun out about, so he had her pull over, and he drove back the rest of the way for five hours. I was like, and then on Monday when I saw him, I was like, so? And he's like, oh, I don't think it worked. And then he told me that story. I'm like, yeah, gee, I
Yeah,
wonder why,
that's
idiot.
not protecting your investment.
No, it's like you
Exactly.
had your ACL repaired and you went and played fucking football on the beach, you moron. Like
Correct.
that's like, yeah, it's
Correct.
so funny. Yeah. No, but that makes sense with the ketamine, same kind of thing.
And so to answer your question, I don't have opposition to it. But I think that there's multiple protocols that exist out there. And it's a matter of working with the prescribing clinician, working with your therapist to determine what makes sense for you.
What do you think of so I hear booster shots or booster infusions. Do you hear
Oh, yeah.
anything on the ketamine for that? Like, oh, I'm gonna go in for my tune up or my booster. Is that
Uh-huh.
My tune-up.
I
I've
I
heard that a few
had
times.
I had a very effective one. I actually had done my series of ketamine, and then I had an experience. I had something happen to me that activated some really old stuff. And ironically, I had to speak on the topic of generational trauma and childhood trauma at a conference in Canada. And I was a mess. I was like, I was ready to cancel it. It was a general session. There would be a couple hundred people there. I couldn't get through the first slide without just breaking down crying. And I'm like, what is this? Like, I can't show up to teach this and be falling apart myself.
Yeah.
And so my therapist said, why don't you go back in for a ketamine therapy and process this? We'll process this together. And I kid you not, that is what I did in there. It was a lot of work. It was probably one of my most intense ketamine therapy sessions. And I was able to deliver, and I was able to make it to that event and do so with grace and not falling apart completely over something that had nothing to do with what was happening to me right now. And that helped tremendously. But again, there was a plan going into it, and it wasn't just the 1 hour of ketamine therapy. It was the 2 hours with my therapist going into it. It was during. It was protecting my window around it, and then it was doing the integration afterwards, and it made a world of difference. It did, and it was very effective. It worked very fast. The depression that I was in lifted very quickly. But again, the one downfall with ketamine therapy, which I think is kind of one of the cons that gets brought up with the Stella block, is that it doesn't always last forever, and everybody's versions or everybody's results are going to vary. But I can tell you with ketamine therapy is that each one builds upon the other. And if you do the work and you do you do it the hard way, essentially, where you don't just walk in, get an infusion, walk out, um, it rewards you. It really takes care of you on the way back. And the what I noticed is that I did a booster in October. I did another one in March of last year, and I haven't had one since. And we're in June. I haven't needed or felt the need. I'm starting to get the looking into, okay, what am I going to work on next with it? But it carried me for over a year.
Yeah. I think life takes maintenance.
Yes.
You know, you go to the
Yeah.
gym. If you have a bad diet, you're not gonna get results.
Yeah.
Right? If you're not communicating with your spouse, your marriage is gonna go to shit.
Mm-hmm.
If you're not getting proper sleep, you're gonna be like crap. And I think, the big thing with this podcast is, it's a lot of honesty, but everything you're talking about is a lot of like disciplinary actions you're taking, and you're taking accountability for yourself.
Yes.
And there's no magic shot. Oh, I'm going to get the SGB shot, and it's going to take care of all my problems. I'm going to go to outer space and rocket ship up there for a little bit, and then when I come back into life, and everything's going to be all hunky dory, and I never have to work on myself again. It's like, no, you're giving yourself a fresh start to deal with these things, to then reset yourself, with the SGB. And there's so much stuff you're talking about here with the ketamine. I'm jealous you guys have done it. I want to do it bad. I think I can definitely it would help a lot. But those daily disciplines you're talking about is a key point. There's nothing. Healing doesn't come easy. A happy life doesn't come easy. The work is not easy. If it was easy, everybody would do it. And with the SGB, with the ketamine, with the talk therapy, there's something you talked about as well. Shane asked about, what do you think about therapy? How should I be talking to somebody? I know for me personally, and I just bring myself up, it's like with us as first responders, when that armor's up, you're talking about therapy. If someone's talking to you in therapy, but you're not hearing what they're throwing down because your nervous system is so hypervigilant, right? Somebody can be listening to this podcast and like, yep, I'm doing that. Yep, I'm going to therapy. Yep, I vibe with the person, but they are not present, right? So I think when you have the therapist, right, they think they are doing the right thing, they're going down the right path. But this is where Shane and I with the SGB and you with the ketamine, with all this path together, that recipe we talk about, it's like this is the recipe that will hopefully help you to focus and guide you down a path to where you can then move forward with more clear intention, if that makes any sense.
Yeah. And I like what you said earlier, so I want to bring it up again, is life requires maintenance. Like that, it's a profound statement. It requires maintenance with everything. If you're training for, a job or an event, or you're studying for a test, like that's not just going to stay with you forever. Like you have to maintain your knowledge. You have to maintain your fitness. You have to maintain your mental fitness as well. And so, I make no promises, and I don't say that ketamine will fix everything. I know people it hasn't worked for. And I know people who haven't worked with it, like have just expected to go get the infusion, take a trip to space, and then come back and be all fixed. And it's not that simple. But yeah, as with all things, life requires maintenance.
Yeah. I will never forget that text you sent, Shane. You sent me your rocket ships after your ketamine. I was like, I'm jealous, man. I want to go to space for a little bit.
That's the emoji I use too.
Yeah, I told him, I was like, yeah, no, I left the planet. My first one was weird. I thought I told him that it seemed like I was watching a trailer of a movie I really wanted to see. And because that 45 minutes just went by super fast, the first one, and I didn't have any dark stuff. It was like super cool, like just
Yeah.
very elemental for me. I'm a big water guy and stuff, so it was just, there was like one or two times I felt my mind going somewhat to like a weird dark place. It felt and then I was like, nope, not right now, and I just like stayed on the good path. And but then the second time I did, I made a mistake. I brought my wife with me, and she was in the room, and um I think my subconscious was so strong that like I never really left the planet, if you will. I knew I knew where I was. I think I knew she was in the room the whole time. So I like vacillated between um, like letting go and being kind of anchored there. I don't know. I don't
Yeah,
really
because
know
you
how to
wouldn't be able
explain
to
it.
take care of her if you were out of your body.
Yeah, I don't know, that makes sense. Yeah. Yeah.
Yeah, that does make sense.
Yeah.
It's the number one
No.
thing I hear from men in this industry, particularly. This is something I very much hear from straight men who have a woman to take care of is in their kids. They go, "Well, I can't do that because what happens if something happens to my wife and I'm under the influence of this?" It's like, she'll be okay. It'll be an hour. Like you'll be fine. But they are so programmed in that way to protect and provide, and it comes from a good place, but it becomes a barrier at times to accessing those parts. So that's really interesting that that happened for you.
Yeah, it makes total sense. I mean, as you said, subconsciously, that's probably what happened. Consciously,
Exactly.
I was like, nope, my intention, I'm all in. I'm doing this for me. This is, I thought I was doing it all the right way, but it's a proof of how powerful the subconscious is.
Yes.
And so I think I kind of derailed it because then on Friday when I went back, it was almost like starting over again. It was like I was
Mhm.
watching the trailer again. Instead of being like on session three, I almost was on session one again. So that's when I realized I was like, you know what? I need to do this under some guidance with Chris and the people I trust that I can,
Yeah.
you know, but it still was a good experience. But I can also see where the flip side of this, one of my concerns and is some of the people that we've helped along the way who it feels so good that's what they go do anytime they have a bad day. It's one of
Hmm.
those, oh, I just need to go get my booster or get my tune up, as I was joking, but it's what they say. And these are the same people who've told Eric and I like the SGB didn't work for them, but they don't realize how well the SGB worked to prime them to go in for that ketamine to really do its thing.
Yeah.
And a lot of those people have resumed the same habits or never even changed any of the habits. And that's the other thing, like you just mentioned.
Nothing
Um,
changes if nothing changes.
yeah, no, well, they just figure, oh, I checked the box, right? I got this shot in my neck, or I went and got this IV full of ketamine. I should be great now. It's like, no, dude, that's not how this works. Like, you have to make major changes to figure out,
Yeah.
and then like actually like rewire your brain. And
Yeah. Yeah.
but
Totally agree. Absolutely agree.
have you seen the Ibogaine stuff? So I mentioned it earlier.
You did. Now so Ibogaine, I've heard talked a lot more in like military circles.
Yeah,
I've heard that. Very promising. So here's my take with all psychedelics. They're all very promising. They're all very healing. They're all very powerful. In the wrong context, in the wrong setting, without the right sitter and provider, like guiding that, can cause a lot of harm. Same thing with ketamine as well. Same thing with ketamine. So all these things, we're playing with these are very powerful tools. And so there are like you've probably heard of it before, but there's a pretty a tight knit network in California of people that do ayahuasca as well. But within the fire service, it's like an invite only. It's very protected, all that stuff. And great. I think that's fine. But it's more so this. I guess where I focus most of my energy and research on ketamine is because it's the one legally accessible psychedelic type medicine. It's technically a hallucinogen, not a psychedelic, not a classic psychedelic like your LSD and psilocybin, your magic mushrooms and ayahuasca. But that to say, even though I don't talk about those other things, and even though I don't have a lot of knowledge about each of them individually, like I do ketamine, I'm a big fan of them. It's just it's the least accessible when in the context of legally being able to access it. And some people don't recognize that. And so that's one thing you won't hear me talk about public. Like I'm talking about it now. Like I'll tell you what I know about it, which is very little. It's just what I've heard on a couple of podcasts about it. And I think it's promising. But it's this idea that as someone that has a platform where I talk about this stuff, I'm very careful about what I talk about. Because let's say I tell someone that I'm microdosing psilocybin and someone goes, "Oh, I want to microdose psilocybin," or that I did MDMA therapy. And they go, "I'm going to go do MDMA therapy." And then they get popped for a drug test because it's an amphetamine and they didn't put two and two together and realize that that wasn't something they could do. So I'm really careful about that. And so by default, I don't research those things as much. So I'd love to hear what you know about the ibogaine.
no, that's I'm pretty much the same. I see the research that's coming out,
Hmm.
the stuff that came out of Stanford last year in January. Chris Romig shared it with us and was telling me and Eric that it was incredible what there was about 30 vets that they took down there, and they did MRIs and brain scans like
Oh, that's
prior and
cool.
after. Yeah, and it was like pretty incredible, like white matter growth around the brain. Uh it's been it's hard for me to I'm very skeptical about stuff. Like I was very skeptical about the SGB. It actually I came out of the SGB thinking I wasted my money. I'm like, yep, didn't work on me. That's what I figured. I'm like, I'm not as fucked up as all these other people. All that stupid shit. And it took me a while to really see it. Like every day, like, oh wow, that would have really pissed me off. That oh, okay, this is so these little wins I would get that I was able to add up over time.
Hmm.
Um, so again, skeptical, but seeing results coming out talking about breaking opioid addictions that people who've been taking SSRIs or other types of stuff for years and years and years, and then all of a sudden they go do this guided stuff down in Mexico because to your point it's not legal,
Yeah.
um and then to see the results coming back, it's as you said, promising. So the reason I asked is because the Texas Ibogaine initiative right now is starting to gain some steam, and I'm curious to see if it's going to get over the line to where they fund some clinical trials to maybe make it in the same vein as ketamine, where that may be something that uh, becomes available for this type of treatment through the vets nonprofit, the Marcus Capone's nonprofit. They're the ones sort of spearheading it. There's a guy named Brian Hubbard that's got a handful of podcasts out there. He looks like the fat dude with the beard from the Hangover movie. Swear to
Yeah.
God, that's what he looks
Alan.
like. But yeah, but he's from like Kentucky and he's got this Kentucky drawl. It's every time I listen to him, I can only think of the dude from The Hangover. But
Yeah.
he's brilliant and he's like a huge advocate for the stuff. And he was working with Rick Perry, the former governor of Texas, to try to move this
Oh,
stuff forward. So
I've heard
it's
of
got
that
some
guy.
steam.
Yeah. No,
Yeah.
and
So
that's good.
there's
I
some cool
mean,
stuff.
MDMA came pretty far. I think they got to stage 4 clinical trials before, the FDA was like, well, we need more. And it's like, Jesus, we don't have 70 more $1 million to dump into another hoop that you want. So it's getting past that red tape too. I hope they can. But that's really great to hear. I mean, I think we're at a point where, these things got banned and they got, scheduled as Schedule 1 and legalized back in the 70s, and it's time to come out of that. It's time to reschedule things and make things more accessible to people to try and heal, because we can't the way we're going, like, and not just first responders, we're talking us as a nation. It's not sustainable. It's not. It hasn't been for a while, and we have these options. We have these things that are promising and are lower risk than doing nothing at all. It's just unfortunate that there isn't more accessibility points to these medicines.
Yeah,
Yeah.
I'm hoping we start to see those programs. I've kind of got this vision that I'm trying to work on where I would like to see a fire department that's our world, obviously, like have their own clinician. So like let's say that we hired Alex to be our resident doctor for
Hmm.
our particular fire department. We've got 6 stations, we've got 70 personnel. And now everybody gets to know Dr. Alex, and you
Hmm.
start kind of getting to know those people. And over time, as you develop those relationships, you start learning what makes each one of these people tick.
Yeah.
And then I think it would also be beneficial to have somebody who's trained in couples counseling to where you could even
Huge.
potentially bring your spouse, right? So, like, let's say you have a particularly rough shift or things have been going on. You look at the calendar, Dr. Alex has 3 p.m. to 4 p.m. open tomorrow. You just plug your name in, it's anonymous. That's kind of a vision I have for a fire department, rather than have to contract it out. Is to
Hmm.
build those like personal relationships with educated people who are invested in, they belong to that tribe as well.
Yeah.
Because I think that's super effective because it gives the personnel sort of that anchor point person that they can trust, that
Hmm.
understands it and has the clinical knowledge, but then also to have that whole arsenal available of like, hey, you need to go to SGB, you need ketamine, you need MDMA, you need ibogaine,
And those
hey,
things
you
can
need
be
to go to.
contracted out and have like a list of vetted people to do it with.
Hmm.
Absolutely. Like having one
100%.
person that is part of the department, that is their, mental health coordinator. I love that idea.
Yeah,
That's a
it's starting
question
to
we
get a
get
little
asked a
bit of
lot.
stuff, but
Sorry, Shane. That's a
sorry.
question I get asked a lot from other guys is like, where do we start? Who do we trust? Trust comes up a lot. Who's competent, right? What doctor do we go to? What therapist do we go to? And like you're talking about, Shane, it's like when you have that blueprint, because at the end of the day, people are still going to have to take accountability and want to go do that. All the tools can be there, and they may still not even want to use the tool. But when it comes back to the trust and someone that is in that tribe, like you were talking about, I think men and women would definitely be way more likely to use the tools and to move forward with that stuff for sure.
Mm-hmm.
Well, like you said about dating, maybe we just need to start like an app, where it's like swiping left or right for your
Yeah.
clinician.
Go on Psychology Today, and then no. Psychology Today is a really good way to filter through a lot of clinicians. And then you just someone's gotta do it. So there's gotta be, if you're, the BC and you're heading this program, maybe you're the one that's gotta go, vet these, clinicians until you find the right one to hire. And yeah, there's programs though. I don't know if I haven't used them myself personally, but I've spoken to a lot of people who have. There's a nonprofit called the Overwatch Collective, and they've got a list of quite a robust list, from what I understand, of clinicians across the nation that are, licensed in different states. So someone can go to them and say, I need help and I'm in Wisconsin. They'll go to their roster of like, what clinicians have we vetted that have we used before? I don't know their process, but it's a good starting point. I think it's important to have those references to go to.
What's that called?
The Overwatch Collective. I know a couple of therapists that do work for them as well, and are some of the clinicians that are available for first responders to work with.
Okay, cool. Yeah, because on these podcast, when I put the headings out, I'll throw that on there, so a
Mm-hmm.
link so people can then follow that hyperlink and go check that out for sure. So the Overwatch Collective.
Well, can we pivot to some of your stuff with grief? I'd be interested to hear. I mean, I suppose we could probably do a whole podcast on that alone, but maybe just scratching the surface of some of your insights on managing grief. I personally went through about a 10-year period of I just had a ton of loss in my life. A bunch of people that were either very close to me or at least connected somewhat to me. And when I went through my own stuff, when I went through my own moment of realizing, like, okay, I need to fix something, like something's off. I believed that I was going to find out grief was a huge problem, that I was, because I never cried. I didn't, I was always quote unquote the rock for everybody else. Um, so I thought, oh, I'm going to be this big blubbering mess of grief as I unpack all this stuff. And it turned out to not really be that way for me. So I'm like fascinated by grief in general. I heard a quote. I don't know what I can attribute it to, but it's always stuck with me, where grief is the culmination of love. And
Mm-hmm.
I was like, I really thought about that, and I was like, because it basically, like, everything ends, right? Like, no matter what you love the most, like, you're gonna lose it at some point. And I thought how crazy that is to think of. It's cathartic, it's beautiful, it sucks, it's
Tragic
a
at the same
weird,
time.
yeah, it's weird to think of it like that, but it's true, right? Uh, so I don't know. I'm just curious what your insights are as you've been navigating all this stuff.
So the things I've come to learn that are true for me when it comes to grief is that grief is unique. Everybody's grief is going to look different. Everybody's grief is going to feel different. Uh, in my experience, grief has been very messy, and grief is the healing process. So the injury is the loss of your home, the loss of your job, the loss of your health, the loss of a spouse, a family member, a friend, whether by death or just separation of the relationship. That's the injury. The grief that happens as a result of that injury is the healing process, and it must be experienced and fully expressed in whatever capacity that means for that person, to allow you to heal from that injury. And so, not everybody's going to go through all 5 stages of grief. And not everybody's going to, they're not going to happen linearly. They're going to happen two at a time, not at all. You're going to skip one. it's going to come up on an anniversary and it's going to visit you maybe 20 years later. Like for my sister, I feel like Mother's Day this year was the first time Mother's Day was really hard for her because her dad had just died. And so that was kind of interesting to witness that in her. And, there's just, as far as first responders go, and firefighters, and what you guys do, or what, you see your firefighters doing is supporting this family member as you're telling them that their loved one is dead. There's nothing more that can be done. And the hardest thing for the first responder to do is nothing, and allow space, like it's holding space, is to just really just shut the fuck up sometimes and let them fall apart, let them roll around on the ground, let them scream and wail and cry and pray out loud, and it'll eventually calm down. Like it'll eventually, like move through them. The thing about emotions is that they're all fleeting. They'll eventually pass. So it's really difficult, especially when first responders are conditioned to hear a bell go off, to get in their gear, get in their vehicle, respond to the address that was associated with that bell, and do something for them. And in the case that you are now shifting from primary patient care to now the family members as secondary patients, in a sense, you're being asked to just allow them to fall apart. And that can sometimes be really difficult. But grief is the healing process, and it demands our participation a lot of times.
How do you so this is something I've always been curious about. How do you feel about I'm sure you've heard stories, maybe even been part of this, where you're on a call, you lose someone to whatever it is, whether it be traumatic or just medical. But I've seen many people that I've worked with who've been affected by it, who have then in the aftermath, either let's say go on, like a kid told me a story one time, probably 2 years after this happened, that he couldn't get the images out of his head from the day before. So he went to the local flower shop, bought flowers, went back to the house the morning we got off. He didn't tell any of us that, rang the doorbell, gave it to him, just said he was sorry, wish he could have done more, kind of thing.
Hmm.
And so I've always wondered, like, good, bad, what do you think about that? I mean,
Generally speaking, it's very welcomed by the community. And it's going to be a case by case basis. I think that the situations where you're spending a prolonged period of time with that family, it becomes more appropriate, which is where I think in hospital staff and people that are in the ICU or PICU for prolonged periods of time, that's why they tend to attend funerals much more than the people that were with them for only 15 minutes, unless it's like a repeat person that had chronic illnesses, and you developed a rapport with the family over time with that. But I don't think there's anything necessarily wrong with that. I also think that there's something that we fail to teach people when it comes to empathy, is that empathy is meant, it's a tool for us to connect with another person, because I guarantee there was something about that call that reminded him of something he's experienced in his personal life, and it was a projection of that. And so his empathy latched onto it, and it was a way for him to connect with them, which can be very serving in a way for the community, especially the person you're helping to support. But empathy is meant to be felt, to allow you to connect, and then it's meant to be released and discharged. And it sounds like if he still has that in his head 2 years later, or I don't know if he did, I don't know if that's where he was coming up with that, but people who carry those things with them for a long period of time, it makes me wonder if they knew to let go of that, if they knew that that was not theirs to carry. And different people are affected by emotions differently. I think it's why we armor up a lot that we do. But I don't think there's anything wrong with that. I think that's perfectly fine. I think the only thing that's concerning is that he felt like he had to hide it.
but he was newer. That didn't surprise me. I mean, in the tough guy world, you don't want to show that,
But that's my
especially until you
point.
build trust.
But that's
Yeah,
my
no,
point
I
is,
mean,
yeah,
yeah,
I
that's
understand why he did, but that to me, from my perspective of understanding mental health and psychology, that's more the concerning part. But obviously, he did what he needed to do. I had a classmate whose husband died while we were in class, because we would, for our PhD program, it was we'd go on campus for a weekend once a month. So for 3 days, we would go on campus. And she was from Oregon or something. We were from all over the country. And she was from Oregon. And while she was in class, her husband had died. She couldn't get a hold of him. He wasn't answering his phone. By the end of the night, she had finally gotten a hold of somebody who went and did a wellness check on him, and he was dead on the couch. And so she got the bad news. Everybody had to get her off to the airport, get her back home and all that. But when she came back the following month, she said that the EMTs and paramedics that were there that had to talk to her on the phone came back a couple days later with a plant and sat with her and talked to her about how he was found, because he got whisked away to the coroners and then eventually released to the funeral home once she got there. So there were so many things that were left unanswered for her, and that's what she
Yeah.
remembers. She remembers that so thoughtfully. And so I've seen how it works on the other end from the survivor's perspective, the family member's perspective, and it means a lot to them when that happens. Doesn't mean we always have to do it, doesn't mean it's always going to be appropriate, but on the times that it happens, I'm sure they'll never forget that.
Well, that's good. That's a good takeaway. That's why I asked, because I struggle sometimes to encourage that kind of behavior, because if it does impact somebody negatively, even though it's coming from a good place, I just want to make sure that we're not making something worse for someone in the public that we're serving, obviously.
I asked that question to, again, a TikTok, and I asked, how would you take this if you were I basically asked people that were not medical, not emergency, not, first responders, if somebody came back and gave you a card or flowers or asked to attend the funeral. And the funeral one was hit or miss, but almost nobody there was a couple in there, but we're talking hundreds of comments. A lot of people said they would have felt like their pain was acknowledged. They would have felt like it was so meaningful. A lot of people said, "Oh, they don't need to worry about me." They kind of turn it on like they've got other things to worry about. But I would have felt deeply touched. I would have felt deeply cared for. You can go find it. It was only a couple weeks ago or a couple months ago that I posted it, but it was really interesting. And I find that with that, as well as the one that we talked about a little bit ago, with the comments from people who received unclear death notifications, they're my experts. Those are the people I look to. And while, yes, I look to the research-based studies and the stuff that's been, published and rigorously researched, there's so much we can learn just from talking to people who have lived that experience. And, I find their feedback to be very valuable.
What about so along the same vein, I've also struggled with this one. You go on a traumatic call as a crew. Let's say it's a four-person company, or a four-person company with an ambulance with two people on it, so maybe
Mm-hmm.
six people total. You go, maybe it's an infant, maybe it's something traumatic, whatever, insert the tragedy. Go back to the firehouse, and we are doing much better now. BCs will come out, call, check on, hey, everybody, I heard that call go down. I heard a 2-year-old. You guys doing okay? Do you need anything from us? That kind of thing, right? 99.9, what do the answer, of course, is no, we're good, thanks, but well, we're taking care of it. We're just talking it out. They're doing better in the firehouses to do those things. But I've wondered, I used to think, um no, just send them home, like just get them coverage, let them go home, let them be with their families, you know that kind of thing. And then I got the other perspective of, like, what if they don't want to go home? And I actually was kind of that way, where I didn't want to be home. I just want to be at firehouse all the time. Like, my norm was what you said, being busy all the time. And so I don't know the right answer to this one. I mean, I realize that every situation is different. I'm a big
Yes.
believer in there's no absolutes, but just from your interactions, conversations, studies, if someone, as a BC, I'm asking you, like, where do you lean towards when a crew encounters, and it could be one of our own. Let's say something
Mm-hmm.
like in Fresno, for instance, we had a fire captain fall through a roof on duty. It was very tragic. He survived it, but a lot of the crews that were on that fire stayed on duty, and that very night had another big fire with a rescue. Should we have sent those people home? Should we have let them work? What's the doctor in you say?
So it sounds also what you're touching on are the terrible 10. Are you familiar with the terrible 10?
No.
It's these it was whoever created CISD, I think, put this out. I'm blanking on the organization's name, but I find the terrible 10 to be very valuable in identifying calls of high complexity that could come with a high risk of adverse reaction, whether it's acute stress disorder or PTSD or something like that, where you need to check in basically. And it includes risk of life or major injury to a fellow coworker, pediatrics, something that makes the news. There's these 10 things, and they're all great, I think, actually, at summarizing things we should be looking for. But I would say you need to come to them with options as opposed to what would you like us to do? Give them the two options you can give them, which is, hey, well, maybe three. I've seen this happen, which is, hey, I can get so and so in here so you can go home. You can stay on duty. Or if, one thing happened, there was a really terrible double fatality with the police department, and they were trying to figure out what they were going to do with the firefighters because they were very close to this police department, and it really affected a lot of them. And so what they did was I remember one person in general was going through a horrific divorce, and they're like, we're not going to send him home to go sit in his camper outside in front of his house that he no longer, he's getting basically kicked out of. So they brought in someone for coverage for him, and they kept him at the fire station but kept him off the unit. So he got to be there with the community. That was his family in that moment. That was his family that he could lean on. But they didn't cognitively overload him with running medical aids all night. And so I would say the best thing you can do is know what your options are and give it to them. So at least they're making a choice, not coming up with a solution themselves. Because no one wants to say, I need to go home. But they might
that's part of the
say
challenge.
option A.
Yeah.
And at that point, unless you have a reason to believe that they can't do it, your hands are tied as a manager, right? But I would say sometimes going in with those couple options, because sometimes going home isn't the right thing. But if they were, some things are lost in hindsight, because them going home and then drinking and then sleeping under the influence of alcohol, which interrupts REM, which will actually compromise the way the hippocampus actually processes that call, could actually be more detrimental than them staying at work. But then if they're up all night, then that also interrupts REM as well. So, it's at some point you can only do so much. But I would say I like the idea of giving them the options that they have as opposed to making it open-ended for them to tell you what they need, because they don't know what they need. They need to be told what to do.
Yeah. That's what my gut tells me. It's, as you know, it's so complex. And Eric's story's one where, he would have stayed in the firehouse after his wife committed suicide. But, his captain, fortunately for him, took a stand and said, no, dude, you need time off. And that story sticks with me as one to try to pay attention to my people, is to say, when do you draw that line? I mean, you have to know, you have to learn. I
You have to
think
know
big
your
part is
people.
education.
You
got
have
to
to
know
know
your
your
people. Yeah.
people. You got to know your people, because people don't want to be, people actually don't want to be treated equally as much as they want to be treated fairly. And what's fair for one person is not fair for another. So that individual that, who he wouldn't have benefited from going home to an empty house or to a trailer in his front yard. You know what I mean? He wouldn't have benefited from going home and having to face his, wife that he's on the outs with. He benefited from being with people he trusted, but not having to be on, the squad that night. So it's just, those are the things you have to consider. But sometimes going home isn't, if you do send them home, there should be some touch points that are established before they go home. Like, hey, I'm going to call you tonight. Right. And then I'm going to call you in the morning. Let them know that that's when you're going to expect to hear from them, because, sending somebody, I remember a friend got sent home by a BC. He's like, I don't want to go home. And he's like, well, you're going home. And then he just proceeded to be isolated from anybody for, the following 2 weeks. He's like, I could have killed myself. Nobody checked on me. I told you I wanted to stay here. So sometimes them staying on is all they've got the ability to do. So not letting them go unaccounted for or untouched, as far as touch points with, calling or visiting, that kind of stuff.
Yeah, those touch points, that's a great thing. And it was a different fire department, you said, right? That he stood at the station that you were just talking about.
Mm-hmm.
And I think I didn't even think about that. With the majority of us, we don't want to go home. We want to be with our buds. We want to be around our crew, because, like you said, it is a part of our identity, and it's a big part of us, of who we are as people. But having those options, I don't want to make this about me, but I was that one that went home. I don't remember the drive home. I don't know how I made it home, because there's no blueprint for this. Kind of like as far as we were talking about with like death notification. It's just in time, we learn different paths that work and don't work. And I like what you said about giving, maybe 2 options, 3 options, but hey, here's something. And once again, just like it's not the other, if somebody's family member died, it's not their job to do our job. Right. So in this moment, it's not the person that's going under the stress. It shouldn't be our job. And I'm only going off my personal experience. I'm not trying to like not take accountability for it. Your brain doesn't know what it's doing. You're so lost.
You don't
You're
always
so
know what you need.
stressed. You don't know what you need. And you need some options, like you said. And I think from that perspective, what you're saying is, hey, here's 2, 3 options. And if they still don't know how to make a decision for them.
Correct.
Right?
Yeah.
Out of respect and camaraderie and trust, all the things we talk about. And those touching points, whatever those touching points are, like, Shane is talking about, or you're talking about, like knowing your tribe, knowing that person, actually investing your time and getting to know your crew, that will go such a long way for that person, whatever they need it at that moment. And that's hard, right? Because our armor's already up. So you're going to have to put some of that armor down on duty, get to know somebody a little bit deeper, be vulnerable with your crew a little bit more. They're going to get to know you better. But then yet in that time of need, now it's like when that person, the RIC team, right, really needs your help, it's like now they feel vulnerable enough to trust that and be like, okay, I trust what's going to happen. Thank you. I'm going to do that. Because the majority I would say the majority are not looking for a cop-out. The majority are looking to take action, take accountability, and then move forward and deal with the challenge. I would say I feel like that's the majority. Am I wrong? You guys tell me. I don't know. Maybe I have some rose-colored glasses here, but I feel like that's the majority of what some want. So I think with the touch points and with some of those options, that's a huge takeaway.
And I also think that relationship has to be built and that trust has to be built long before you need it. So I'll give you an example. When I worked as an EMS coordinator for a really large department, I mean, I never learned everybody. There was like 1,200 people at this department. But what I did is anytime I had anything that I CQI'd anything that looked like it was challenging, based on the way they wrote it or based on the fact that it was a PEDS call, I would just send them an email and say, hey, just got done reviewing your call. All looks good. Looked like a tough call. Let me know if you need anything. That's it. Or, hey, I noticed a documentation error here. I unlocked it for you so you could fix that. Also looked like a really challenging call. You had to navigate this. And just acknowledging that it was rough. Not asking them, hey, was that hard for you? Just acknowledging that looked a little challenging. Let me know if you need anything. And before you know it, they're showing up in my office to talk about stuff because I've established that kind of two-way communication before they actually needed it. And so that's something I also hear is somebody had a really bad call that killed a CHP officer. And, all these people were showing up at the station. And he's like, where were you guys the last 28 days? I've had the shittiest calls of my life the last 3 weeks. Nobody's given a shit about me until this thing ended up in the news. So that told me that individual wasn't, that relationship wasn't fostered leading up to it. So the challenge actually isn't in that moment. It's what's happened in the months to years leading up to that moment. And that can also be something that can be, planned for, plan for the worst, hope for the best kind of thing. But yeah, start by just, you see something like, hey, how was that? You good? Okay, cool. Let me know if, in moments that are very low likelihood that they need something, right? Hey, okay, cool. That looked really challenging. Just acknowledge it and see where that goes.
Yeah, I think we talk about this a lot is building those relationships, making probationary employees feel safe, that, hey, you can mess up, you're part of the tribe, even though you're on probation, and making sure they know that. And because once you start that early on, that person hopefully carries that same method forward
That's
as they
culture.
become a senior firefighter. Yeah. And that's how you truly change the culture. Exactly right. So
exactly.
So you use the word safe. I don't want to, it's like making making sure the rookies are safe. There's plenty of times, right? They shouldn't feel safe because you're going to lose your job if you don't do good enough, right? So what do you think about that, Alex, as far as like terminology, but making sure you're not creating, a victim mentality, but letting people know, letting men and women know, like, you're safe here, be yourself. It doesn't lower the standard, but you can open up. Like, what are your recommendations on as far as like communicating that to new people?
I think there's often a misconception that safety means no accountability, and that's not the case. I think a person who feels safe to mess up will also really respond positively to getting checked, the way that they need to. They're like, oh, yeah, I messed up. That was on me. And I think it actually there's a potential for it to build a lot healthier of an environment than it is to detriment, at least in the sense of like, you got to hold it accountable, right? You have to,
Mm-hmm.
speak truth to when something's off. But that's the thing is like, I look at it as so when I went into a new department, my goal was to build their trust first. I wasn't going to go in and nitpick every little thing that they were doing wrong. Was it wrong? Yeah. Did it need to be accountable first? Yeah. But you know what? They had been doing that for years before I came along. Me jamming them up on the first week isn't going to do anything. So I first had to make it so that I had to lay the foundation so that they knew when I came to them about something, their license wasn't being compromised. I was trying to help them be better. And so that's an element of safety. You might not like the word, which I don't love the word either. I have a little aversion to it, of like safe spaces kind of thing, but there's truth to it. Is that if you can make someone feel psychologically and physically and, their nervous system safe to mess up, then you can also hold them accountable when they do. I don't think that they're mutually exclusive.
Yeah, no, you explained it. That's what I was looking for. I liked how you
Cool.
explained that on a deeper level, for sure. I
Good.
like that. That was good.
Good.
And I think other people will resonate with that too. Um, yeah, no, that was a
Yeah,
good
and
response.
sometimes the most compassionate thing you can do and the best thing you can do for somebody is hold them accountable and is to discipline them. I met somebody recently that, was saying like they changed once their manager put them on unpaid leave. Like they were just running amok, doing whatever they wanted, getting away with whatever they wanted until somebody held them accountable and said, "Sorry, man, like this is what's going to happen." And they went, "Oh," like it was the wake up call that they needed. And I know I've seen a couple of cases where people just keep trying to protect the person over and over and over again. It's causing more harm than anything. And it causes harm to the culture because nothing will deteriorate a culture more than than a manager's or a leader's tolerance of bad behavior. So, that's also something to keep in mind.
Yeah,
These are great questions. This has been fantastic conversation with you two.
Yeah.
yeah. Yeah. I think it's been awesome. I think before we end here, what is your take? We've talked about this, but with the subconscious, we've got the ketamine, we've got the SGB, we've got the personal accountability, all the stuff that we talk about. Life takes maintenance. With the ketamine, with the SGB, all this stuff. What is your take on meditation? Because I get a lot of questions on meditation. I don't want to do that. It's too boring. That won't work for me. I can't slow my thoughts down. All these things. So, what are some nuggets? What's your take on it?
Well, I don't have a daily practice with it. I will tell you. Not that I don't believe in it. I've just never built the practice. It takes practice. It takes a habit. And I think it's when I have had it, I don't have one currently, but when I have had it, it gave me time. So I like the saying is that prayer is speaking to God and meditation is God speaking to you. Whatever that means, whatever the definition of God means to you, if you have a belief in anything outside of yourself in a higher power. And I think there's a big misconception that meditation is supposed to be quiet, and it's not. It's supposed to be that you don't. So the analogy of driving down the street and having all the trees pass by you, those are your thoughts. The idea is to sit there and let the thoughts go by without attaching to them and going down a storyline. Can you sit there and be with your breath and something come up about groceries and you just let it float by, and something come up about your ex and you let it float by, and something come up about that thing you have to do tomorrow and you let it flow by? I mean, the ADHD on top of the really busy schedule, on top of the, short attention spans that we have, I find it to be both a product of our social media, our phones, but also the efficiency of our brain. I think our brains are just evolving right now, and we're seeing evolution in action. And so many other things are going to come up. And the idea isn't to fight them, it's to let them be there and just sit for a moment by yourself. But we're almost never by ourselves anymore. And so maybe I'll wake up tomorrow and do a little meditation. Wouldn't be a bad idea.
No.
But it only has to be a minute, just a moment to yourself.
Yeah.
And I do think it's a very healthy thing. And like I said, I have had a practice in the past. I'm just it's not something I'm in shape with right now.
Yeah. No, you explained it. I was looking, the explanation and your analogy of the trees and stuff. That's a great take on that. I think it's great. I think it's been a great podcast. I think for sure it's been awesome. There's been a lot of nuggets, on this for sure. And, I'm going to go back and listen to this one a couple times, a few times, half a dozen times, probably. There are some, because when we're talking here, it's hard, to really take nuggets out when you're paying attention and trying to think of things. So, I thank both of you, that we're doing this, and thank you, Alex, for coming on. And I'm super stoked that, we met a year ago or so at the college, and this is what you're doing. And, it's something I think we all have a passion for, is to help our own.
I think it's great what you guys are doing. I think you guys having the platform and being, I think it's really important that men in this industry be talking about this, because, it's not likely that you see that kind of vulnerability expressed, and that kind of, discussion of things taking place. And I think it's so important. So really appreciate you guys are doing this, and that you've got a growing audience that is going to benefit from the different guests that you have on, the conversations that you're willing to lean into. So thanks for having me on.
Where can people find you? I know you have a website, and anybody interested in trying to get you out, why don't you plug some of your stuff so any of our listeners can actually find you?
Thank you. So emergencyresilience.com is my website. You can find me on pretty much any social media platform, but I'm the most active on Instagram. And my handles are all at Emergency Resilience. So find me out there somewhere, say hi in the DMs. I answer as many as I can. And I love the conversations that take place there. So
Awesome. I'm assuming you can
Awesome.
tailor curriculum to any of the agencies that might need it, right?
that is correct. So I do custom curriculum builds, as well as I have my speaker page should be going up soon, where you'll actually see a list of my current courses that I deliver. There's a handful of them. And I also have online courses. So if you are in need of any continuing education, I am a CAPC accredited CE provider. So these courses are usually approved in almost every state. CAPC is kind of the largest, accreditation organization. So we have a couple classes up, and 2 more coming up in the nenext. Oh, I should probably say this, actually. This would be a good plug. I have a ketamine therapy CE course that I built, and that's going to be free. That is going to be available, and it is going to be free to providers. It'll be worth CEs as well. And so that will be available. I should get they're being edited right now. The course is being edited right now by my video editor. Should be back by the end of the week. I was actually working on the rest of the curriculum before I jumped on with you guys now. And so that'll get submitted for accreditation and should be available in the next few weeks, but it will be free.
Awesome. And those CEs will apply for EMTs and medics?
EMTs, AEMT, paramedic, yeah. MICNs even in California can get them. So.
Oh, cool.
Cool.
Yeah.
Awesome. Well, hey, thank you. It's been nice talking with you. I really appreciate the time, and maybe we can have you on, or love to have you on again anytime you're available.
Let's do it. How about after Eric does ketamine therapy and we can all exchange experiences?
There you go. Yeah.
Yeah. I'll be able to tell you
And
guys what
after
it's
I
like
do
going
the
out to
Stella
space and coming
block for
back.
my heart rate. And
Oh
so
yeah,
it's
Yeah.
you
like
do.
it's
You're gonna have to
88.
tell us. Yeah, where are you at right now? You're in the Midwest, or
Yeah, we
you're?
just had a tornado,
Nice.
so it was fun. I mean, honestly, tornadoes don't scare me as much as earthquakes do. So actually, earthquakes don't even scare me, but I should say you get a lot of warning with tornadoes. So, you can actually track those.
Yeah, that's fun. I'm
Nice.
actually in a safety officer class this week, and today one of our exercises was a tornado that we were dealing with as a USAR team. So it's kind of funny. Um, what? Yeah, I don't know. I don't know if we know anybody out there that does the SGBs, but if you make your way to SoCal, let us know, and then we'll hook you up with Dr. Omig and
I still work
in
there
Irvine there.
sometimes, so I'll keep that in mind. Yeah, I'll look into it.
Y-
I will. I'm always, once you mentioned the heart rate, that's been a point of contention and topic of conversation for a couple years now. And it's always my heart rate's always been high, my blood pressure's always been low, and I'm like, it's just how I am. But maybe it's my nervous system. So
Well, your dude can thank us later because
yeah,
my I, I have
Yeah.
photos, Alex, that I've shared of my wife's heart rate at the hotel on the walk from the hotel to the clinic and immediately following. And at the hotel was 110. On the walk, it went to 140. And my
yep,
wife is not out of shape. She's, in shape. She eats well, things like that. And she went in, she got the shot, and the picture I have of her watch is 77. And
yeah.
that's immediately following the
Oh my
SGB. And
gosh,
it's stayed that way for a year and a half now. It's been that
she
she did
sounds
that.
like me.
So
She sounds exactly
yeah,
like me. Like he's like, you're in SVT walking up the stairs, and I'm like,
yeah, but
it's a
you don't
lot of
feel it, right?
stairs.
Like you're just like, no, it's just yeah. And she's but yeah, that's what convinced me. I mean, I've told the story ad nauseum on the podcast about when I first got introduced to it. People were like, "Dude, you gotta get this shot. It's they give you a shot in your neck. It resets your brain." And I'm like, "Yeah, sounds fucking
Yeah.
great. What are you talking about? Like, you're not sticking a needle in my neck, idiot." And then a lot of the stories I heard from people were just very anecdotal. I'm like, yeah, yeah, sure, okay, yeah, you're floating on clouds, yeah, okay, good for you, whatever. But then when I was talking to like level-headed dudes that I seemed were reasonable, and then we were looking at data points like that, that was
How about
very
heart rate
convincing.
variability? Did you watch that?
Yeah, so that's an interesting one because my baseline's in the 30s, and I fluctuate. Like I think yesterday, and just so funny you bring that up. 2 days ago, I did NAD plus IV therapy,
Hmm.
and um uh trying to think of like okay, so basically like I did that was like a 3.5 hour infusion, and it's supposed to be this great thing for antioxidants and for
Yeah.
like your cellular health and mitochondrial health and all this stuff. And I didn't really feel much from it. I had these little waves as I was doing it, but my HRV spiked. It was 48 yesterday, which was
Yeah, I've heard of
surprising.
that
But today
happen.
it's back in the mid 30s.
Yeah.
So I was hoping it was gonna like sustain. But again, I'm traveling. I'm on
Hmm.
the road. I'm in a hotel in Carlsbad right now.
Yeah.
I won't be home for another probably 2 weeks. So there's all these weird things like that. But to answer your question, HRV doesn't seem to like massively change from the SGB.
Okay.
And what I understand is originally when I was looking into that, HRV was, hey man, if it's low, oh my gosh, that's so bad. But
Yeah.
it's more about your baseline. So like
Got it.
whatever your baseline is, if it stays within that range, that's good. It's when you
Okay.
see those wild swings, low or high,
That makes
that's
sense.
when you start paying closer attention to it. It's not
Okay.
like I can meditate and get mine up to 100 overnight. I think I'm sympathetically driven. I think that I'm actually kind of curious about the way our bodies even process things like dopamine after being so chronically exposed for so long. Because I
Hmm.
don't feel things the same as I think other people. Like I get out of my cold plunge and I don't have this rush of endorphins like other people. I don't feel the big dopamine hit. I feel better. I feel good. I like but I don't get overwhelmed. And so I'm curious about those types of things and how our hormones work and chemicals and everything
Hmm.
else. So.
Okay.
But
Well, you convinced me to look into the Stella because that heart rate thing is appealing. I don't want to run out of heartbeats too early. So,
nope, it's just a pump. Get that thing
yeah.
fixed.
All right. All right, guys.
Yeah.
Cool.
Awesome. So we can reach you again one more time. Emergency resilience, correct?
Emergencyresilience.com. You'll find my classes and ways to get in touch with me. Send me an inquiry. And yeah, I go all over the country. And then there's the online stuff as well. And then there's a ton of information on my website or on my social media. We have a lot of conversations there about a lot of different things.
Okay, awesome. And Shane, once again, where can we reach you at?
ricfirecaptain@gmail.com.
I think you're gonna have to change that because you're no longer a captain, dude.
Oh,
Yeah,
You're a
it's all
chief.
right.
Whoa, I got him a
Yeah.
captain.
I'll always be a pirate captain. There's no chiefs on the pirate boat, dude.
There you go. Nice. And then you can reach me at epadgettcoching@gmail.com. Thank you guys. We'll see you on the next one.
good night.